Perfecte.
I la cadira.
No t'ha mogut cap endarrere, oi que sí? Vinga, quina hora és? Què vols? Sí, un programa. Vale, quan ens diguis, Joan, i a 2:15 en punt comencem. Has obert? Sí. Doncs som-hi. Bona tarda a tothom i benvinguts. So, good afternoon and welcome to this meeting in order to present the optimizing transplantation of primary immune deficiencies that is organized together by the Barcelona PID Foundation, by the Hebron Hospital i el Banc de Sang i Teixits here in Barcelona. I just want to thank you all for being here, thanking the speakers, thanking the attendees, and mainly thanking our colleagues from the transplant team who are a key stone of this project, both the meeting and the cure of these patients. I'm here on the table together with my colleagues from Barcelona PID Foundation and Banc de Sang i Teixits, and I'll give them the word in a while. We'll try to be tight to time because, I mean, we have a lot of things to say in a short period of time this afternoon. So I will ask all the speakers to remain on time if possible. So with that said, I give the word to Roser Vallès. She is the director of the Plasma Self-Sufficiency Program here in Catalonia, and she's working at Banc de Sang i Teixits. So Roser, the floor is yours.
Thank you so much. It's a real pleasure to welcome you to this important event, especially at this moment that coinciding with the World Primary Immunodeficiency Week. So this week represents a big opportunity for raising awareness and taking action in the fight against these diseases. First of all, I would like to express our gratitude from the BST to the hospital, of course, but especially to Carlota Villar as Vice President of Foundation PID, and to Dr. Pere Soler, President of this foundation, and also head of the Pediatric Infectious Pathology Unit at this hospital. They have been essential in the organization and successful of this meeting, so thank you so much.
Thank you.
And today's agenda will cover various topics related to transplantation and immunodeficiencies. But before getting into transplantation, these patients need substitute treatment with immunoglobulins. Therefore, they need plasma donation. Catalonia is a solidarity driving region. According to the WHO, we are the best in altruistic donations, and we try to push in this condition in donation, plasma donation. We strongly believe that social awareness is the key to improving the life of many people, especially those who suffer from immunodeficiencies primary. This week, we have organized a lot of campaigns of plasma donation around the country, around Catalonia. But it's important to note that here we can give plasma, we can donate plasma 24 times per year. It means once each 15 days, but our average is around 2. We have a lot of work to do. We have a long way to go. And what is our goal? Our goal is to arrive to ensure the treatment with immunoglobulins to all of these patients who have not therapeutic alternatives. To arrive to this objective, we need to perform 64,000 donations of plasma. In 2023, we registered 30,000 donations of plasma. So it means we have to double this number. It's for that that we would like to arrive at this objective in 2026. And it's for all this that it's essential to understand the significance of this donation, because for the patients, they are imperative, these donations. As professionals, healthcare professionals, we ask you to support us and to have a active participation in these donations. And we are sure, we are confident that we can achieve plasma self-sufficiency and guarantee the well-being of many vulnerable patients in Catalonia and in Europe. So thank you so much and have a good meeting.
Thank you a lot. I mean, it's obvious that the role of BST in terms of achieving this self-sufficiency in plasma, and also its role in transplantation and selection of donors and so on, is extremely important for our patients. So thank you very much for your collaboration and for being here. And now it's my pleasure to introduce Carlota Villar. She is the Vice President of the Barcelona PID Foundation and the mother of a PID child. So Carlota, please, the floor is yours.
Muchas gracias. Thank you. It's a pleasure for me to be here today with all of you. As introduced by Dr. Soler, I am Carlota Villar. I'm mother of a boy with a primary immunodeficiency, and I'm the Vice President of the Barcelona PID Foundation. Our foundation was established in 2014 by a group of professionals in PID and family members of patients with the aim of bringing together all individuals, professionals, and entities working towards primary immunodeficiencies. Our foundation acts as a bridge between healthcare professionals, research groups, pharmaceutical companies, and patient associations to strive for excellence in education and research in PID and offer patients a comprehensive healthcare. In 2018, we established a patient council to gather patients' needs and to seek solutions and responses. Among these is the experience of transplantation as a key point of the therapy for PID patients. This is why we proposed to Vall Hospital and the BST to organize this event, for which we are very grateful. Thank you again.
Thanks a lot, Carlota. Again, listening to patients is actually what leads our daily job, and that makes it full of sense. Yes, go ahead.
Just want to express my gratitude also to the national and international speakers today for their participation and for sharing their expertise in this field. Thank you all. Muchas gracias.
Gracias, Carlota. So now, after this short presentation, this meeting will have 3 blocks. The first one will be focused on the, let's say, all limitation of donors, and that will be chaired by Sergi Carola and Cristina Díaz-de-Heredia. The second one will be on immunological reconstitution after transplantation, which is key for patients with primary immune deficiency, and I'll be honored to chair it. I was co-chairing that with Francesc Rodilla, but sadly he couldn't join at the end. And after a short break, we'll have the pleasure to hear our colleagues in terms of transplantation in adults, which is a key point in the management of these patients. And we are very happy to close the meeting with a video experience, the testimonial video by a lot of families and patients with primary immune deficiency that underwent transplantation here at the hospital. So with that said, I think that we can go down and ask Sergi and Cristina to come to the floor and start with the first roundtable. Thank you very much.
Good afternoon, everyone. It's a great pleasure to open this first session of our program on optimizing hematopoietic cell transplantation for patients with inborn errors of immunity. I am Cristina Diaz-Heredia from the Division of Pediatric Hematology and Oncology and Stem Cell Transplantation here at Hospital Vall d'Hebron, and I will co-chair this first session with Dr. Sergi Querol. Sergi, maybe you would like to introduce yourself?
Thank you, Cristina. I'm Sergio Querol. I'm director of the PST, Blood and Tissue Bank Cell Therapy Department. And we are very happy also to contribute in this meeting.
So in this first session, we will discuss whether the donor is a limiting factor in stem cell transplantation. We would like to have many questions from all of you, so we encourage the audience to ask as many questions as you can. For those who are online, please send your questions to the Q&A chat, and we will read them after the presentation. So we will do the discussion after the two presentations. We have two great speakers for this first session, and we will start with our first speaker, who is Dr. Andrew Jennery. He is professor and honorary consultant in pediatric immunology and stem cell transplantation at the University Children's Hospital of Newcastle. And as you know, Newcastle is one of the most experienced centers in Europe in pediatric primary immunodeficiencies. He will talk about the possibilities of infusing specific T cells subpopulation after transplantation, avoiding T cell subpopulations that can lead to complications in our patient. So, Dr. Jennery, please.
Hi, can you see me and hear me okay?
Yes.
And can you see my presentation?
Yes.
Brilliant, right, okay. So I'm actually at a meeting in Riyadh at the moment, so I've kind of experienced, not personally, but there've been some complications. So first of all, thank you very much to the organisers for asking me to come to your meeting. It's always nice to talk at your meetings. It's a shame when I have to do it remotely rather than being online, rather than being there in person, but hopefully another time. Whoa. So these are my disclosures. Actually, I'm just going to close this down for me so that I can see better. So, as you know, we have been collecting data from transplantation for inborn errors of immunity in Europe, really since the first European transplant in 1968. And these were the first data collected from SCETID, published in 1986. And you can see at that point, HLA matched donors were doing better than HLA mismatched donors. Unfortunately, over time, whilst our HLA identical donor transplants improved, the same cannot be said for the HLA non-identical T-cell depleted transplants. And these are data from the next update of the SCETID series, which was published in The Lancet in 1990. So you can see in the more recent era, HLA identical transplants are 95 to 100% survival, whereas our T-cell depleted transplants remain stuck at somewhere between 50 and 60%. In Newcastle, we actually started, really the very first transplants we did were using T-cell depleted donors. And initially, we were using Campath-1M as our depletion agent between 1987 and 1998. We published this in Cytotherapy in 2001. We'd had 30 transplants for patients with SCID with an overall survival of 63%, mirroring that survival demonstrated in the Lancet paper. And the infections were predominantly from, the deaths were predominantly from infection, again, predominantly viral infection, although there were patients with graft versus host disease as well. In 1998, along with much of Europe, we moved to the magnetic bead technology, and we're using CD34 selection for our T-cell depletion. We did 22 patients like this with better results, with a survival of around 85% or so, but again with deaths which were predominantly infection. And one of the things that we felt during that time was that actually overall our chimerism, and particularly our myeloid chimerism, was better with Campath than it had been with the CD34 depletion, and you can see that in grey here. So that kind of led to some concerns. One of my now sadly retired colleagues, Mario Abanen, used to talk about the soup of stem cell transplantation, and it wasn't just the stem cell that was important to get good engraftment and good immune reconstitution, but actually you needed many, many other factors as well, including perhaps other cell types and cytokines and growth factors and the like. And that with a pure CD34 selection, whilst you had got the stem cell, you were missing important ingredients of the soup, and that changed and diminished how we had our engraftment. We then moved to CD3, CD19 depleted transplants. We felt that these engrafted more quickly than the CD34 selected grafts, and that was perhaps better overall for viral infection. But even so, we were quite worried when patients had virus, and actually didn't do quite as many of these transplants as we had done for the CD34. This graph here, courtesy of Suhan Lum, one of my colleagues in Newcastle, demonstrates the kind of evolution of our program in Newcastle with Campath 1M, with CD34 selection, with CD3, CD19 depletion. And then in 2012, we changed a number of things from marrow to PBSC in 2007, to TCR alpha beta CD19 depletion in 2012. But also, and I think it's important in transplant not to take one thing in isolation, but a number of things go together. It was in 2007 that we started using fludarabine and treosulfan with or without thiotepa as part of our stem for our conditioning, rather than traditional busulfan cyclophosphamide, which we had used prior to that. And I think that's probably important as well. So this is the conditioning protocol that we use for our TCR alpha beta depletion. We follow the European protocol, thiotepa if it's being used, although not, we don't use thiotepa for SCIDs, but increasingly for other conditions these days, fludarabine, treosulfan, ATG grapholon, and rituximab. And we published our data along with Great Ormond Street, although I think the majority of the patients
Andy, sorry,
yeah.
Andy, we're not seeing your slides. I mean, we're still seeing the one with the chronological now. It seems to be moving on, not yet.
Do you see the alpha beta depletion there?
Now we see that.
Pie chart. Pie chart?
Yes.
Right, okay, that's the one I'm on.
Okay, great.
Okay, thank you for that. So these are our results that we published along with Great Ormond Street, although predominantly they were our patients, 25 patients, 26 transplants. And there are a number of interesting observations from this. The first is that in patients who had either absent or resolved infection by the time of transplant, we had a very good survival indeed. Whereas in those patients who had a persistent infection at time of transplant, the survival was really quite woeful, down to only a third of those patients. There were not so many, but even so, it was really quite disappointing. The second thing is that the number of conditions that are being transplanted has changed quite significantly, and I'll come back to that. Right, do you see the new slide?
Yes, yes.
Okay, great. So this just shows the immune reconstitution of CD4 naive and CD8 naive T cells over time, and you can see good naive T cell recovery, and also that the TCR gamma delta cells decrease over time as the alpha beta cells increase over time, which is what you would expect and hope to see with normal immune reconstitution. Now, as this platform came into play, not just in Newcastle, but in other centres as well, there's been a dramatic shift in what we have seen in terms of transplants. So the data from the SCETID paper, which I haven't shown, looking at results of survival for SCID and non-SCID, which we published in 2010, of those patients, of which there were over 300, 3/4 of patients receiving T-cell depleted transplant had SCID, and only about 1/4 of patients had non-SCID. When we come to look at TCR alpha beta depletion, we see that the picture has completely changed. And we see SCID is now about 1/4, and non-SCID patients are 3/4 of the patients receiving T-cell depleted transplants. And I think, you know, within the story of transplantation, from time to time, there have been paradigm shifts in practice. And I think this really is one of those paradigm shifts. And just to kind of illustrate that here, these are our data from 2012 to 2019 of T-cell depleted transplants, 55 patients, and you can see 24% are SCID, and then you have a mix, MHC class 2 deficiency, chronic granulomatous disease, DOC8 deficiency, A20 haploinsufficiency, PI3 kinase deficiency, RIPK1 deficiency, STAT1 deficiency. There's a whole spectrum of diseases that we are now prepared to tackle using a T-cell depleted transplant with the TCR alpha beta depletion platform than we were prior to that. And that, I think, is a real game changer. Whoa. When we look at the graft composition of the CD34 cell dose in the TCR alpha beta transplants compared to the other platforms we had used previously, you can see a much higher stem cell dose. And that's mainly because in these we're using peripheral blood stem cells rather than bone marrow. There's also a higher T cell dose, but of course this is a majority of gamma delta T cell receptor T cells rather than alpha beta T cells. We have showed over time, and it's not just because of the depletion, but because of other things as well, including conditioning, including new antivirals, new PCR techniques, and so on. But our survival overall for TCR alpha beta is better than it was for the other T cell depletion, with a 5-year overall survival of 95%. Now, if we look at multi-center series, donor outcomes in the 2020s, we can see in the most current SCETID data set, which was published in 2022, this is SCID patients only. And actually, it's before these new T-cell depletion platforms came into play. We still had good results from matched family and matched unrelated donors, but the T-cell depletion was still hovering around about 75% survival. Similar results from America, where we have the T-cell depletion is not as good as the matched unrelated donors. However, there are center effects. And these are data from SCID patients from our center in Newcastle, published between, I think it was 2010 and 2019. And you can see that there is no statistical difference here between the type of donor that we use and the outcome. And in fact, if you look at the graph, you can see that our TCR alpha betas are better than the rest, but statistically, there's no difference. But I think that's encouraging, because what it means is that when we have a patient come to us and we don't have a matched donor, either matched unrelated or matched family donor, we can confidently say, in our center at least, that the results of a T-cell depletion depend not on the donor, but rather on the status of the patient. And we can see that this is looking at specifically our TCR alpha beta depleted transplants. In patients, in young patients less than 5 years of age, we have an overall survival of 86%. However, that doesn't translate as well to the older patients, where we have an overall survival of only 41%. So in summary for this part, outcomes after the haploidentical transplant using the alpha beta CD19 depletion in experienced centers are excellent, and that it is a safe alternative donor procedure in SCID and in non-SCID inborn errors of immunity. In SCID, we now tend to use a haploidentical donor rather than a matched unrelated donor. And to be honest, if the patient is well, which often they are in the era of newborn screening, we'd often rather use a haploidentical donor than a matched sibling, because we are unable to use peripheral blood stem cells with a matched sibling, and we get a much higher stem cell dose and therefore much more stable engraftment using a haploidentical donor. In non-SCID inborn errors of immunity, and the pie chart really demonstrates that there are increasing indications of transplant. Importantly, though, age is an important predictor of outcome, and transplant should be performed as early as possible. Now, it's easy to say that, but of course, it's not always easy to do that, because we have to, we have to transplant the patients when they come to us, and we don't get a choice about how old they are when they arrive. Just as an aside, I think it's really important to point out, these are data from the group in Moscow, who were T-cell depleting using alpha-beta depletion, matched unrelated donors, mismatched unrelated donors, as well as haploidentical parents. And they were able to show identical results regardless of the donor. Now, the conclusion from their manuscript was that you shouldn't spend money on looking for mismatched unrelated donors when the results are as good as a haploidentical parent. And I think that's absolutely true. But the converse of that is just occasionally you're not able to use a parent for a number of different reasons. And it may be that all you have is mismatched unrelated donors. And again, we can be confident that the outcomes of using a mismatched unrelated donor are as good as any other donor that we use using an alpha-beta depletion. So going back to our overall survival according to age at transplant, we looked at patients who'd had T-replete transplant less than 5 years and more than 5 years, and they have very good survival of around 90%. When we looked at T-cell depletion less than 5 years, it absolutely mirrors the T-replete transplants. But when we looked at the T-depleted more than 5 years, as I previously showed you, the survival is down to around 60%. So this is the group of patients which tends to be non-SCID immune deficiency, combined immune deficiency particularly. And perhaps unsurprisingly, when we look at the cumulative incidence of viremia, we see it is much higher in the T-depleted grafts in the non-SCID PID rather than in the T-replete grafts in the non-SCID PID. And this is the group that is the really difficult group that we are now beginning to tackle. So if you are a non-SCID and you are older and you do not have a matched donor, then your chances of getting through transplant successfully are significantly less than if you are a younger patient and you don't have virus. And of course, we know that it is these combined immune deficiency patients that come older often have the virus. And in order to get around that, we have initiated a trial using a CD45 RA depleted CD45RO T-cell add-back. And so this is the backbone of the trial. The conditioning remains the same, although there is a slight difference, which I will talk about in a minute. We give the stem cell transplant as I have described on the day of transplant, and then on day +7 in the trial of non-SCID combined immune deficiency patients, they get a CD3, CD45RO enriched memory T-cell infusion. Now, we're doing this in 2 parts. The first part is a dose finding, and it's randomized and blinded. 3 patients in each group will get 0.3, 0.6, or 1 × 10⁶ per kilo of CD3, CD45 RA depleted cells, aiming to give less than 2.5 × 10⁴ per kilo of CD45 RA cells. We will analyze the results at that point and go forward using the dose which we think is giving us the best result in terms of less GVHD and more viral clearance, and enroll hopefully a further 26 patients into the trial. The second part of the trial, which is retrospective, is that we are doing a pharmacokinetic study on all of the chemotherapy and serotherapy agents that we are giving. Now, we will not have those data in real time in order to determine how it influences the outcome of the patients, but we're hoping once the trial is closed and we have these data, we'll be able to determine, and particularly, I guess it's things like ATG and rituximab that we're interested in, how much of an effect they have at day 0, for instance, of influencing the engraftment of our stem cell infusion and then our CD45 RA depleted add-back. Now, we did generate some pilot data before we initiated the trial, and this is just from one of our patients that we did that. This was a young lady, not so young actually, who's 11 years of age, MHC class 2 deficiency, and she was pathetic actually. She arrived in Newcastle from overseas weighing 14.14 kilograms. She was CMV positive, the donor was CMV positive, and she also had a pre-transplant active infection of norovirus, parechovirus, cryptosporidium, and salmonella, and was TPN dependent with enteropathy. She got our standard conditioning. She got an infusion, but then on day +1, because we hadn't worked out the details of what a trial might look like, we gave her a T-cell add-back. Now, I think if you look at this patient, it is not the patient that you would rush to do a T-cell depleted transplant on. She did get a little bit of grade 2 acute skin GVHD, and it may be that residual ATG affected some of the cells, I don't know. She got some ECP, which she responded to. She did have a problem with CMV viremia and did need some foscarnet, but you can see that she got a fairly rapid T-cell reconstitution, and we were able to control the CMV. She cleared ultimately all her infection. She came off TPN and went back home cured of MHC class 2. So I think we have now enrolled 3 patients onto our trial. Our first patient has been dosed on day 7. I don't know what T-cell dose they got because it's blinded. And we have a couple of other patients who are going through, some of whom are only on the pharmacokinetic part of the trial, others who will get the additional T-cells. And hopefully in a couple of years' time, we will have some data to demonstrate whether this methodology actually changes the results from our more than 5 years old combined immune deficiency patients who have a worse outcome at present with T-cell depleted transplants. So I'm going to stop there. I'm going to acknowledge the people particularly involved in setting this up: Mary, Sophie, Suhan, who is running the trial, and in the lab as well. And I'm happy to take questions at the end. Thank you very much.
Thank you, Andrew, for this excellent presentation. As you said, we will do the questions at the end. Now, I want to introduce the second speaker for this session on donor as a limiting factor, trying to clarify what is the aspect related to depletion techniques that we can use in transplantation practice. It's a pleasure for me to introduce Jesus Fernandez. Jesus Fernandez is will be the director of the Cell Therapy Center at Blood and Tissue Bank, and he's very highly experienced in managing cell processing for transplantation in our hospitals in Catalonia. So, Jesus, 20 minutes for your presentation.
Thank you very much for your kindly presentation, Sergi. I'm going to show you our experience as a cell processing laboratory regarding T-cell depletion in Catalonia. I want to thank all the organizers for making it possible this meeting and for inviting me to show our results. So this is the session overview. I will talk a little bit about our cell therapy service to make you better understand our facility and all the equipment and the technology that we use for the T-cell depletion, the activity, the results, and finally the conclusions. This is our model. We have a particular model in cell therapy in Catalonia. We call hub and spoke, and we have a single cell processing laboratory that provides service to 11 transplant centers and are connected to one collection centers. All the collection centers and the cell processing are under the same tissue establishment. So this makes it possible to have the same quality control. And our laboratory process all the transplant product for these 11 transplant centers. So we have we provide more than 500 stem cells for transplantation, and we receive more than 100 CAR T cells per year. So this is the map of Catalonia. We are in Barcelona, located the cell processing. And as you can see, there are the transplant centers. Most of them, they only have, some of them autologous transplantation, and 5 of them in Barcelona, they have allogenic transplant program. And here in this particular hospital in Vall, they have allogenic, autologous, and also pediatric transplant program. This is the map of our classified room. So as you can see, we have different class levels. So in Spain, we process stem cells and T-cell depletion in a class D. This is the purple color. And the other rooms, as green or blue, are class B or C. They are where we manufacture advanced therapy products or where we process tissue. But for the T-cell depletion and other minimal manipulation, we perform them in a class D. This is the picture with 2 biological safety cabinets, and we are really high automatized. And we also have close to this room, the cryogenic room with a control rate freezer to cryopreserve the products. And this is the equipment that we use for the T-cell depletion. We use Clinimax, we have 2 of them, and we use Sepax just to adjust the volume before do the T-cell depletion, and also to wash the labeled monoclonal. So this is only to highlight some points that you are probably you already know, that hematopoietic stem cell graft, they are really heterogeneous. So they include the stem cells, but other cells like T cells, NK, and B cells. And some of these cells are involved in some critical complication like graft versus host disease, like CD3 T cells. And in order to avoid or to decrease this complication, we can manipulate the graft. And this is what we are talking about today, to enrich or deplete some cells of the graft. So this is a scheme of the positive cell selection. So we mix the labeled CD34, for instance, monoclonal, with the graft, and then this is incubated. And after this incubation, the cells goes through the column, and there is a magnetic effect that retains the positive cells or the labeled monoclonal cells that are retained in the column, and the other cells are discarded. And finally, the selected cells are eluted and used it for the transplantation. This is a positive way, but we can also do a negative cell selection. In that case, you can see in the figure different populations. So we can select the cells that we want to discard. So for instance, T cells like the 45 array or alpha beta, and then the other cells that goes through the column, they are the cells that we will use for the transplantation or for the immunotherapy. And sorry that the colors maybe you cannot see very well, but this is the activity along all the years in our laboratory. As you can see, the yellow color is the number of CD34 selections. So this is the procedure that we have performed more in our laboratory, almost 500 procedures. And in the last year, we started other T-cell depletion like CD45 array or TCR alpha beta and CD19 depletion. So they are the cellularity results regarding the CD34 enrichment. So you can see in the table the number of CD34 at the start of the enrichment procedure. The final cell dose, this is a median of around 5 million of CD34 cells selected. And you can see the started CD3 number and the depletion, and the recovery is around 67%. This is very similar that you can find in the literature. And most of the procedures that we use in this CD34 enrichment was as the transplant for transplantation. There is a protocol ex vivo manipulation here in adults in hospital by the Bron. So most of them we have performed for transplantation, but in other cases we perform it as a boost. So sometimes allogenic patients have a poor graft function. So one treatment is to do a boost with CD34 cells. And in the other table, you can see the diagnosis of the patient, most of them with malignant disease and others with non-malignant disease. And this is a study published with our college, adults hematology department here in Vall, that they compared patients who were submitted to ex vivo T-cell depletion versus post-transplantation cyclophosphamide as a prophylaxis for graft versus host disease in non-haploidentical donors. And as you can see in red line, this is the T-cell depletion with the ex vivo manipulation, and the engraftment was faster in neutrophil and in platelet in compared with the other group. And in the right side, you can see the acute graft versus host disease, and in low, you can see the chronic graft versus host disease. And as you can see, the rate of acute and chronic graft versus host disease was very low with the ex vivo manipulation. But in those patients, our colleagues saw a poor reconstitution and some infections. So they are going to start a clinical trial, phase 1b, in order to evaluate the safety and immunobiology to do a prophylactic infusion of gamma delta lymphocytes and NK from HLA identical donors. So we are going to include 8 patients. The protocol is going to be the same, so T-cell depletion with a CD34 enrichment, but with the negative fraction, we are going to perform alpha beta CD19 depletion, and then we are going to cryopreserve and to do the DLI and to be infused in day 30, 60, and 90 after transplantation. So the aim of the clinical trial is to analyze tolerance and effectiveness. And secondary, we are going to test all the reconstitution tests in order to evaluate this effect. Again, we in the last years, we also performed a CD45 RI depletion in 6 patients in Catalonia. You can see the results of the graph collected, the graph that was used after the CD34 selection. The negative fraction was performed a CD45 RI depletion, and the recovery of those patients and the depletion. In those patients, they were diagnosed with acute leukemia in pediatric patient, and the donor were haploidentical. And as you can see, this is a publication not only of the patient that were treated here in Catalonia, but also in Spain, around 28,7 patients. This is the engraftment of the patient really fast. And this is the rate of acute and chronic graft versus host disease. And here you can see the relapse, overall survivals, and something that was unexpected was an infection with human herpes virus 6 that in 2 patients provoked encephalitis, and one of them with neuropsychology sequence, and the other patient with a graft rejections. And finally, in the last year, we have also performed CD45 alpha beta CD19 depletion in 5 patients. In all patients, all again pediatric patients, haploidentical donors, and 3 of them with inherited disorders, one with lymphoma and other one with a myelodysplastic syndrome. And this is the graph and the cellularity of the product at the beginning, when started the procedures, and the final dose. And as you can see, in those patients, the dose that they were received was higher, probably because they are pediatric patients and the donor are adults. So to conclude is that the immunomagnetical technological has been used not only in our laboratory, but also in the cell transplantation field. Our cell therapy service at BST has an experience in immunomagnetic selection and depletion technology. So in most cases, we use it CD34 enrichment, but we also validate and have experience with another T cells platform like CD45 array depletion and alpha beta, and we also perform NK selection. So in the incorporation of this strategy in immunodeficiency patients would be possible in our laboratory very quickly. So I want to acknowledge to our colleagues in the hospitals. Here are our colleagues, pediatric colleagues in Hospital Vall d'Hebron, but also in Hospital Sant Pau, ICO Hospitalet, Sant Joan de Déu, ICO Badalona, and also our laboratory. Yeah, this is a process that is really time consuming. So yeah, we have a fantastic team. So yeah, all of them, thank you very much. And thank you for your attention. And if you have questions, really happy to try to answer.
Okay.
Podem veure el xat? No hi ha preguntes? No questions from the chat?
So Pere told us that there's no question in the chat. So I think, Andrew, you are there?
Yeah.
Okay, so thank you. So let's start from here. Some questions, Christina.
Okay, thank you very much, Andy, for your presentation. It was really excellent, so I enjoyed it very much. And I have a question regarding your patients above 5 years old, that you say that a T-cell depleted transplant with the alpha beta, well, the manipulated transplants, it's not the better way to transplant these patients. So would you extremely recommend to find a match unrelated donor or even a cord? Or and you say that one of these, the reason is infections, but what about graft failure? Could you comment on that, on these patients?
Yeah, no, thank you for your question. So the reason, I guess, that we are doing the trial is actually to address this. So we know that it's the over 5s, particularly when we know that they've got viral infection, and of course they're more likely to have, they are the ones that are less likely to do well. And the problem is that they get reactivation of virus, and then it's difficult to treat that. What we hope is that by giving the CD45RO cells, we will counter that infection. Now, of course, there are downsides to that, because if you've got a, well, I suppose you're unlikely to have a situation where the donor is negative and the patient is positive, particularly if you've got a related donor. So it may be that the patient is CMV positive, and it's likely that the donor will also be CMV positive if they're a relative. The disadvantage will be if there is a virus mismatch and the donor doesn't have that viral specificity. One of the advantages, because one of the problems we face when we've got patients going through transplant who have severe viral infection is one option is to try and get hold of viral specific T cells, but they're a little bit difficult to access. It depends on the center. It depends on whether you've got access to the donor. Sometimes it actually depends on the virus. And we're hoping with the CD45RA depletion that we will have a polyviral specific, if you like, pool of T cells that will affect a number of viruses that the patient may have. Now, it's a trial. It may not be successful, and we may need to go back to the drawing board. But I think our hope is that, having identified that this is the problem in that group of patients, by giving a T cell add back that has viral specificity, we will at least counter some of that problem. One of the advantages is that it's much cheaper than going for the viral specific T cells, of course, because the the component of cells that we're looking at come out in the TCR alpha beta component. Normally that would go in the bin, but what we're actually doing is taking that component and enriching it for the C.
Oops. We lost you, Andy. Let's see.
Let's see, 5 seconds. No, it's not coming.
No.
So we can continue.
Yeah, we can. I
with-
think we can
with-
move on and see whether we can.
Yeah.
take
Okay,
feedback.
so a question now for Jesus relating to the alpha beta T cell depletion. Obviously, you show that our experience is limited compared to what Andrew, but but one of the thing cautions that we need to have is about the quality of the collection in these cases, because we are talking of a graft in a patient that will be conditioned at the time. And what are some critical issues regarding this, and alternatives for activating other plans if the doses of C34 are not correct?
Okay, thank you, Sergio, for your question. We, as you say, we have seen that the number of CD34 cells are really important, and in our experience, in the last cases, we discussed with a physician team, with a pediatric team, to achieve a high number of CD34 cells. So we try to manage that the donor, in case that doesn't mobilize very well, try to even use plerixafor. So in some donors, to consider it and to have a graph with a really high number of CD34 cells. So this is one issue that is really critical in our laboratory to start the procedures, and also to discuss with the clinical team in case we don't have a really high graph, to have alternative plans in these patients.
Okay.
Okay, any question from the audience here? No, I have a question for both for Cristina and the BST, because I love to hear from you, because when you are a physician who's taking care of the patient pre-transplant, and you know all this data coming from Russia and coming from Newcastle, and they look great, despite it's true that other centers were not able to do so. and you hear Jesus saying, well, it's feasible, and you have a great team in transplantation. So what are the limiting factors for increasing the use of this technique in our primary immune deficient patients? I mean, I'm sure they are, and we don't know it since we are not transplanters, but from the other side, I'd love to hear, I mean, is it actually, as you said, quickly to start with it? I mean, is it reasonable from a pediatrician point of view? So that's what I would like to hear from you two as a team who is at the very end deciding what to do or not.
Well, maybe I can start. So I think that now at the Catalan Blood and Tissue Bank, I think you are ready to go on this technique. So it has been a period of practice and try to be sure that all the procedures are done in the best way, and that we can assure, as he told us, the number of cells and not to fail in the graft manipulation. This is very important. Also, as Andrew showed us, that the results for young patients, the mite sibling donors, mite unrelated donors, the cords, and even the haplotransplants depleted with manipulation or with post-transplant cyclophosphamide showed the same results. And maybe we are used to use other donors instead of haplo donors, because every group has their own experience. However, results, as he showed us very well, of haplo donors in older children, as children above 5 years, are not as good as we would like. So I think we have commented in the session that we have to think what donor we have, what patient we have, if the patient had previous infections, and many factors to see what's the best donor for each patient. So, but from a technical point of view, I think that now we are ready to go on more procedures.
Yeah, exactly. From a point of view, of a technical point of view, we are ready. So we have a close relationship with all the clinical centers to make sure that we are not perform more than one T-cell depletion a day. So as we serve to 5 transplant centers who can request that T-cell depletion, we have to make sure that, to not making the same day, but for the other, we are ready. This is really important, the graph that we also discussed. We did an internal protocol. So also we can share the experience that Vall has with the last transplant to others transplant groups in Catalonia. So we are ready to start.
That's great. It's a pity that we lost Andy, because I was ready to ask him what type of infections, because they are mainly viral. And I would like to ask you, Cristina, and also your team, if they want to participate, about what is your opinion about the use of new antiviral prophylaxis and therapies with letermovir and maribavir? I mean, because I don't know if they're used once it's approved. Now it's only approved above the age of 12. So we still have the gap from 5 to 12. But what about in patients who are older than 12? Do you think that despite they are old, if we use this letermovir prophylaxis and we can use maribavir or another virus, we should expect to have better results than what Andy has shown us? Or do you think that other viruses still will play a role and will leads to this poor prognosis in old, let's say, old patients?
For the haplotransplant, not only CMV, it's an important virus, also adenovirus and herpes 6 virus. Jesus showed us very nicely in the report of this CD45 array depleted transplant that encephalitis by herpes 6 virus was an important problem. So not only cytomegalovirus plays a role, also adenovirus and herpes are very important virus. Letermovir, we have now approved for patients above 12 years old and for some selected groups of transplants. Of course, haplotransplants are a group of transplants and we could use, but till now, until day 100 post-transplant, not after, but it seems that we will have the probability to use even later. That would be important, and I think letermovir, it's important for CMV, but we have also these two viruses, adenovirus and herpes, that are very important. So the infusion of CD45RO cells maybe could be help, but we don't know. So it's important to study in a trial. This is the best way. And I have a lot of questions to Andy about this, but unfortunately, we lost him. So.
Yes, it's a pity because we tried to pick him up, but he's not connected so far. So I'm sorry for the rest of attendees, because I'm sure that they may have other questions for Andy. And I don't know if in the chat is there any question for Jesus? I don't know, Sergi and Christine, you have other questions, and not we could.
Well, let me do a comment also in having a resource for treating the infection. I think this is important. Apparently, is the major cause of death or the procedure failure. So having alternatives, you mentioned chemical alternatives, but also having cell therapy alternatives like CD45RO. I don't know if they do the RI depletion in the negative fraction. I don't think so, because it is an alpha beta. So maybe they need to a second day of apheresis, right? But also to say that we have available in Barcelona specific T-cell treatments using also the Miltenyi technology, that is the interferon gamma positive selection. If you are available, this as advanced therapy product is also important if you go to this type of treatments, to have cell therapy alternatives to treat complications that you may have after the implementation of these therapies.
Yeah, that has been an important advance that we had with the CTLs, the specific CTLs for virus. So I think Laura will talk about that also in her presentation. And I have a question to Jesus, is regarding that, of course, to assure the number of CD34 cells in the product it's really, really important. And that's why we are using peripheral blood for manipulation. But do you see any indication of manipulating bone marrow? There is any protocol, or do you have any information about that?
I think it performed in the past, but right now I don't know really much experience to using bone marrow for CD45 RA or alpha beta depletion. I don't know, maybe Sergi has more.
I think we lose the competency, the validation from processing bone marrow. I think it's not an easy graft to process. There are many cells that need to be removed prior to the selection. Normally through a density gradient, so the recovery of CD34 try to be low, and obviously again, it's possible. We did, but it will require very thorough validation for doing that again. Yeah. At least in our hands, obviously. In other laboratories, this may be possible. Easy.
Okay, is there any question in the chat? No questions, so let's move to the following section.
Yes, thank you.
Thank you very much, all the audience and the speakers.
Thank you, Sergi. Thank you, Christina. Thank you to the speakers. Again, apologizing for the loss of connection with Andy. We'll see if we can ask him back, but he was in Riyadh, so I don't know if this is going to happen. And I want to also thank you for keeping on time, which is extremely important for the audience. So I'll close this micro and get to this one. I hope you can hear me. Yes. So let's close it one. Yes, it's done. So let's move to the second roundtable. That it's up to the what I think is a very important point for all transplanted patients, but mainly for patients with primary immune deficient who come to the transplant with a defective immune system, which and then it's quite easy, let's say, to check how things are going. And for that we have 3 speakers. We have two local one and an external one. Emma Enric from Banc de Sang Teixits, Alba Parra from Beer, and Eliadat from Montreal. So with that said, I think it's time for Emma to give us her presentation. Emma is a postdoctoral researcher in the histocompatibility and immunogenetics group at Banc de Sang Teixits here in Barcelona. We do work with them in this project. It's wonderful to have her on the other side because she does an excellent job. So Emma, the floor is yours. Thank you for coming.
Sorry. Good afternoon. First of all, I would like to thank the invitation to present this part of the talk today. That's about the applications of T-cell and B-cell receptor sequencing in the context of inborn errors of immunity. I have divided the presentation in 4 parts. First of all, I will do a little introduction of T and B-cell receptors. Secondly, I will explain the strategy that we have developed in our institution for T and B-cell T and B-cell receptor sequencing. Then I will explain the different parameters that we analyze in a T and B-cell repertoire, and I will present the reference values that we have obtained in 2 control cohorts of healthy individuals. And finally, I will explain some applications of T-cell and B-cell receptor sequencing in the context of inborn errors of immunity. So the T-cell receptor is expressed in T-cells and is responsible for recognition of antigens presented by HLA molecules. It consists of 2 an alpha and beta main chains. And on the other hand, the B-cell receptor is a membrane-bound immunoglobulin that is expressed on the cell surface of B cells, and it consists of 2 heavy and 2 light chains. All of these chains contain a variable domain, which is the part of the receptor that is in contact with the antigens, that is encoded by the DNA recombination of the variable diversity and joining genes. In this recombination process, some nucleotides are inserted and others are deleted in the BTJ binding sites. And this process makes it possible that each newly developed lymphocyte contains a unique T-cell or B-cell receptor and is the source of the extremely variability of the T and B-cell repertoires. In our institution, in the Banc de Sang Teixits of Barcelona, we have developed 2 strategies, one for sequencing the beta chain of the T-cell receptor and another one for the heavy chain of the PCR. The first one is already validated and implemented in our laboratory, and the second one is under development. Both strategies use DNA as a starting material and consists of a multiplex PCR for the amplification of the PDJ rearrangements. A second PCR is performed for library preparation, and purification is performed by gel extraction. For sequencing, we are using MySeq system of Illumina, and MixCR, BGIL, and BDJ tools are using for analysis. The study of the T and B cell receptor, in the study of T and B cell receptors, we can analyze different parameters such as the diversity of the repertoire, the distribution of the serial region length, the frequency at which each variable and joining genes contribute to the rearrangements. We can also define the proportion of each different clonotype inside the repertoire, and as a consequence, we can detect those clonotypes that are more expanded. We can also search whether the clonotypes detected have been previously described in the literature, which means that they are public. We can track clonotypes of interest in different samples or over time. And finally, we can also compare different repertoires to know their similarity. Now I'm going to explain these parameters in more detail. And for the first 3 parameters, I'm going to show you the results of the TCR virus sequencing of in 2 cohorts of healthy individuals, 1 cohort of pediatric patients of 20 individuals, and another cohort of adult individuals with 33 individuals. As for diversity indexes, we use these 4 parameters, even though in the literature there are different variations of them. The observed diversity or richness is the number of unique clonotypes that we can detect in a repertoire, and it will depend on the number of initial cells studied. In this case, we in the pediatric cohort, in the right side of the slide, there are the reference values for both the pediatric and the adult cohort presented as the mean and the range. So in the pediatric cohort, we studied 5,000 T cells and detected around 27,000 unique clonotypes. And in the adult cohort, we studied 100,000 T cells and detected 41 unique clonotypes. The normalized Shannon diversity index ranged from 0 to 1, with higher values indicating a higher degree of diversity. And in this case, both repertoires show a high diversity with values nearly 0.9. The inverse Simpson's index ranged from 1 to infinity, with higher values indicating a uniform distribution of the clonotypes and lower values indicating the presence of enriched clonotypes. And in this case, in the adult cohort, we saw that this index was lower, which means that there are more enriched clonotypes compared to the pediatric cohort. Finally, the D50 index is the number of unique clonotypes comprising the 50% of the repertoire, and with lower values indicating a higher clonality. The distribution of the CDR3 length is also a measure of the diversity of a repertoire. In a polyclonal repertoire, it is expected to have a normal-like distribution of these lengths. However, in pathological repertoires, this normal distribution could be broken due to the presence of clonality or because CDR3 are shorter or longer than expected. Here, both cohorts presented a polyclonal diverse repertoire with CDR lengths from 10 to 20 amino acids and a mean length of 14 amino acids. In a healthy repertoire, it is also expected to have different variable and joining genes contributing to the BDJ rearrangements. However, it is frequent that it is normal that some variable or joining genes appear more frequently in this recombination process. For example, in both cohorts, we found that TRPV21 and TRPJ11 and 27 were the most represented ones. On the other hand, in a pathological repertoire, the frequency of these segments could be skewed with overrepresentations of only some combinations. In the study of these T and B cell receptors, we can also detect the different clonotypes that appear in a repertoire and their frequency. For example, here I present the 10 most frequent clonotypes in a sample. And for example, the first one was described in the literature to recognize an antigen of the EBV presented by the HLA 0201, which means that it is a public clonotype. we can, when having the nucleotide sequence of each clonotype makes it possible to monitor them in different samples or over time. For example, here I present the read frequency of the 7 most frequent clonotypes in 3 samples taken from the same patient at different time points. And as you can see, the first 4 clonotypes decrease, whereas the last 3 clonotypes increase over time. So we can monitor them. And finally, we can compare different clonotypes from different samples by comparing the number of unique clonotypes that they share, or by using different similarity index, such as JACAR or Morisi-Tahor. The T-cell and B-cell receptor sequencing can have different applications in the context of inborn errors of immunity. On the one hand, this technology can be used to better understand how these pathologies could affect the functionality of the T or B repertoire. For example, in this article, authors had the objective to perform sequencing of the TCR beta of a group of patients with inborn errors of immunity to investigate the characteristics of their repertoire. They analyzed 19 patients subdivided in a typical SCID, AT, ACF1 and 2, and they also compared them with 14 age-matched healthy donors, a group of donors. They use different parameters to analyze the diversity of the repertoire, such as the Shannon-Weiner's index, the variable gene usage, CDR3 length, and the nucleotide composition of the CDR3 sequences. They saw that the TCR beta repertoire diversity correlated with the severity of the clinical phenotype, and that immune repertoires in patients with atypical SCID, AT, or ICF2 showed a restricted diversity compared to controls. They also saw that some TRP variable genes were markedly reduced in some patients compared to controls. As for CDR3 length, they saw a bias toward shorter lengths in SCID and AT patients or longer lengths in ICF2 and ICF1. And interestingly, they saw that there was abnormality in the CDR3 amino acid composition with a higher percentage of titers and residues in 80 patients, which this could explain that these patients sometimes has an increased risk of autoimmunity. In our institution, we have also analyzed 3 patients with drug deficiency that they come from the Vall Hospital from the group of Perasole. And we analyzed different parameters of the T-cell repertoire. We saw that Shannon-Weiner index and inverse symptom index, which represent diversity, were significantly decreased compared to the reference values that we obtained in the control pediatric cohort. We also saw that the CDR3 distribution length in these patients did not follow a normal-like distribution, and this is because they had a very high clonality. And finally, the frequency of the TRP variable and TRP joining genes was skewed in all patients with overrepresentation of some combinations. On the other hand, T and B cell receptor sequencing can also be used to monitor immune reconstitution after transplantation in these patients. In this article that I present, authors investigate whether longitudinal analysis of the TRB repertoire will describe the quality of the T-cell reconstitution following hematopoietic stem cell transplantation in a cohort of 27 infants with SCID. They perform a follow-up at 3, 6, 12 months and yearly post-treatment, and they use Shannon entropy index to measure diversity. They saw that there was a severe restriction of the repertoire diversity at 3 months post-transplant, followed by a significant improvement by 6 months. They also saw a significant correlation at 6 months between Shannon index and the total number of circulating CD4 naive T cells, which is a non-biomarker predictive of the quality of immune reconstitution. And importantly, they saw that diversity improved more rapidly following successful transplantation compared to those patients that had an unsuccessful transplantation. So they proposed that a restricted TRB diversity at 3 months post-transplant may identify patients at risk of failure of immune reconstitution, thus prompting a second intervention with UpToDate. So authors conclude with all this data that this support the incorporation of high throughput sequencing of TCR repertoire as a valuable biomarker following cellular therapy for SCID patients. In summary of this talk, T and B cell receptors play a crucial role in the adaptive immune response since they are responsible for antigenic recognition and cell activation. Characterization of PDGA rearrangements by NGS is useful to study different parameters of a T or B cell repertoire, such as diversity, CDR3 length, variable and joining usage frequency, and also to identify clonal expansions and monitor T or B cells of interest. And finally, T and B cell receptor sequencing has different applications in the context of IEI, both to expand knowledge on how these pathologies affect the functionality of T and B cell repertoires and to monitor immune reconstitution after transplantation. I would like to thank all people that have collaborated in this work and all of you for your attention.
Thank you, Emma. If you want, we can take questions at the end of the full session. So now it's time for Alba after this wonderful presentation by Emma. Alba Parra is a biologist. She is a predoctoral researcher of our group, Infection and Immunity in Children, here at BIR, and she is currently developing her doctoral thesis on immune reconstitution after stem cell transplantation in pediatric patients. So thanks, Alba, and the floor is yours.
Thank you for the presentation. Good afternoon. I want to thank the organizers to inviting me. My name is Alba Parra, and I'm a biologist and PhD student at BIR, and I'm going to show you a presentation about our experience in immune reconstitution by the Brown Hospital after hematopoietic transplantation in patients with inborn errors of immunity. Hematopoietic stem cell transplantation involves the infusion of healthy hematopoietic stem cells derived from bone marrow, peripheral blood, or umbilical cord of a compatible donor with the aim of restoring normal immune function in the recipient. The success of transplant depends on several factors: precise identification of the underlying immunological defect, appropriate donor selection, patient conditioning, and post-transplant monitoring. After transplantation, it's crucial to detect the graft engraftment, the presence of graft versus host disease in order to establish the adequate treatment, and as well as the evaluation of immune reconstitution after transplantation, which is the moment when the protection of infection will be restored, improve the overall survival, and determine the moment when the anti-infective prophylaxis established after transplantation should be stopped. The immune reconstitution in the innate immunity is rapidly established after transplantation, and the adaptive immunity recovers very highly variable genetics that are strongly influenced of several factors, such as basic diagnosis, donor type, manipulation, graft manipulation, stem cell source, pharmacological prophylaxis, or the development and treatment of graft versus host disease. Which to lead a delay in graft engraftment, especially of B lymphocytes, requiring of these patients the immunoglobulin replacement therapy despite a successful hematopoietic stem cell transplantation, a treatment in which is often in supply problems. Regarding the T cells reconstitution, NK cells, gamma delta T cells, and Treg rapidly recovery within weeks to normal levels after transplantation. CD8, CD4, and memory B cells recovery as early as 1 to 2 months. And reconstitution of naive T cells pool highly depends on thymopoiesis and can take years, starting around 3 months after transplantation. As Emma and Rick explained before, here we have an article explaining the difference between the diversity of TCR repertoire in 2 patients. The first patient is a patient with successful transplant where we can see at 3 months clonality expansion and followed by significant improve of this diversity at 6 months, and below we have a patient with failed transplantation. Regarding B cells, the reconstitution of B cells take more time. The transitional B cells are increased at the first time, but the levels are normal in the following time points. B cells are low in the first two years, and switch memory B cells is the reconstitution is more early in compared with IgM memory cells, which are reduced in the long term. In this study, the patient of this study stopped the immunoglobulin replacement therapy at first and the second 2 years after transplantation, and we can see that they continue with the normal levels of IgG, IgA, IgM, and different subclasses of IgG in the follow-up. In this study, they studied the reconstitution of B cells, studying the Ig heavy chain CDR3 repertoire, in which we can see how the first patient had a fast recovery of the CDR3 repertoire in compared with a healthy donor. And below we have a patient who had a complication after transplantation, and we can see defect in this repertoire at 9 months, 3 months, and at the beginning of the post-transplant period. With all of this, I want to present a work of my doctoral thesis, in which our hypothesis is to assess the immune reconstitution in pediatric patients with inborn errors of immunity will allow define the moment when proper and complete immune reconstitution of the patients occur. And this will help determine to appropriate time to cease the replacement therapy without increasing the risk of developing infections, complications, and thus optimize the use of immunoglobulins as a treatment. Our objective is to study the immunological reconstitution, identify a correlation among all the indicators of immune recovery, define the appropriate time to cease the immunoglobulin replacement therapy, and determine the utility of studying the diversity of TCR and BCR repertoire in assessing immunological reconstitution. To this end, 2 studies are developed. On one hand, a retrospective study involving the evolution, involving the study of immune reconstitution in a cohort of pediatric patients with inborn errors of immunity who have undergone of hematopoietic stem cell transplantation and required immunoglobulin replacement therapy post-transplant. We collecting data, demographic data, clinical and transplant data, and laboratory data in the follow-ups visit of these patients for 2 years. Since 2021, we have had a protocol in which we include the parameters to be evaluated at different points after transplantation in the first year, before conditioning, after 1, 3, 6, 9, and 12 months. The lab parameters is blood count, lymphocyte immunophenotyping, CD45 RAD-RO, and memory B cells, thymic emigrants, immunoglobulin, lymphoproliferative function, and differential chimerism, as well as a specific test depending on the inverter of immunity, for example, the oxidative test in chronic granulomatous disease. From the second year to 5, the parameters are the same as before, but they are analyzed annual or every 6 months, depending on if the patients are with immunoglobulin replacement therapy or if the lymphoproliferative function is normal or altered. On the other hand, a prospective study with new protocol, we evaluate the immune reconstitution, the patients transplanted in 2023 and this year, 2024, and we collect the same demographic, clinical, and transplant data and we are expanding the immunological study, including the T-cell subset, T-helper subset, T-regulatory cells, TCR alpha beta, B-cell subset, recent thymic emigrants, and immunoglobulins, including the subclasses of IgG. And also we include the study of TCR and BCL repertoire in different time points post-transplant in these patients. As a result, in a core description of retrospective patients, we include a total of 36 patients, most of them from the group 1 of IEI, the combined immunodeficiency, and group 5 of congenital defects of phagocytes number or function. The patients were transplanted from 2016 to 2023. And here we have the data of transplant. The age at transplant of this cohort of patients is 2 years. The distribution of gender is very similar. The survival is the 94%, only 2 exodus patients post-transplantation. Regarding the donor type, the majority of patients are from match unrelated donor, followed by match-related donor. The conditioning type, the majority of patients received reduced intensity conditioning. Regarding the source of stem cells, the majority comes from bone marrow, and 72% developed after transplantation graft versus host disease, 61% in acute form and 11% in chronic. And the median month at the immunoglobulin replacement therapy is discontinued is 10 months. And we can see a proportion of patients that continue with this therapy after 2 years of transplantation. Here we have the results of chimerism in different months post-transplantation. Some of patients with chimerism in peripheral blood and another ones with chimerism in T lymphocytes, highlighting the importance the study of chimerism in lymphocytes populations to not overlook the chimerism details in these populations when we study the chimerism in peripheral blood. I want to show you the results of the reconstitution of T, B, and NK cells in this cohort of patients. I only want to highlight that the general data show that patients reach to the lower level of normality range at 9 months. in CD3, CD4, CD8, and CD9, but NK cells reconstitute more faster, and we can see how these cells reach the normal range at more early at 3 months post-transplantation. Regarding the different factors that can influence immune reconstitution, we observed a difference between the type of conditioning. In red, we have reduced intensity conditioning that we can see best reconstitution in compared with the other group. Regarding the stem cells, we not observed the difference between these groups, but we have to take account that the low end of the last two groups to conclude something with this. Regarding the graft versus host disease, we see difference between the patients who develop the graft versus host disease. In gray, we can see the patients who had not developed this complication and have a better reconstitution than the other group. Regarding the immunoglobulin replacement therapy withdrawal criteria in that protocol, say that we have to present B lymphocytes, positive IgM values, positive isoagglutinin, no infections, and no immunosuppression. And if we look the results of CD19 and IgM in patients in the month post-transplantation when the treatment was discontinued, we see some patients who don't reach this lower level of the range of normality. Therefore, it was possible a decision based on clinical end data and not on all established criteria. And on the other hand, the prospective study, we are working now in this part of the study, but I want to show you some data. We include so far 6 patients from group 1 of immunodeficiency, 1 patient from group 3 and another patient from group 5. This is patients transplanted in 2023 and 2024. Regarding transplant data, the age of transplant is 7.5 years. We have more predominant male representation in this cohort. The survival at this moment is 100%. Regarding the donor, we have 3 patients with a match unrelated donor and 2 patients with haploidentical donor. 3 patients received RIG conditioning and 2 patients MAC. Regarding source of the stem cells, 2 patients comes from bone marrow, 2 patients from umbilical cord blood, and 1 from peripheral blood. And at the moment, no one developed the graft versus host disease, and all of them are with immunoglobulin replacement therapy. We are working on this project, so we have evaluated the time point of preconditioning of the 6 patients. 5 of them have reached at the first month post-transplantation, 3 at the 3rd month, and 1 patient have 6 and 9 follow-up post-transplantation. And I want to show you some preliminary results of this study. Here I want to present the TB and NK cells of these patients, and just to comment the difference between patient 2 in color blue and patient 1. Patient 2 is a RAG deficiency patient, and we can see how at 3 months post-transplantation has a much better results than the patient number 1. And as Emma explained before, we have able to establish a normal range of the index of diversity of the TCR repertoire in pediatric controls and also in RAG deficiency patients. And we have a preliminary results of our patients, including in the prospective study. And the except of patients number 3 and we can see low diversity in 3 months because this patient has complications post-transplantation with immunosuppression and the patients number 1 and number 2 have this increased diversity in their repertoire at 3 months. The patient 1, we can see a little decrease in 6 months, but this is normal because at 3 months, the patient have the repertoire of the donor, and in 6 months, the patient start to develop the new repertoire of TCR. So as a conclusion, the immune reconstitution after stem cell transplantation is a complex and dynamic process involving multiple cellular populations and mechanisms. There is a significant variability among patients, and it's crucial to study each patient individually to fully understand their post-transplant immune response. However, most patients present an acceptable immune reconstitution by 9 months post-transplantation. There is a proportion of our IEI transplanted patients that are without immunoglobulin replacement, without accomplishing all criteria per protocol. The addition of TCR and BCR monitoring may predict the immune reconstitution, and fully understanding the immune reconstitution required a comprehensive analysis of the immune system over time, both quantitative and qualitative. So to finish, I would like to thank all the teams involved in this work, the infection and immunity in pediatric patients, translational immunology and child cancer and blood disorders group from Vall d'Hebron, and histocompatibility and immunogenetics lab from Banc de Sang Teixits de Barcelona. And of course, to all of you for your attention. Thank you very much.
All right. So with that, we'll move to the next presentation and we'll take the questions at the end of the session. And I hope that Eli Adati is already connected. Eli, are you there?
Yes, I am.
It's great to see you again, let's say.
Likewise, yes. We don't stop seeing each other those times. That's great.
Turns to be a problem. So the thing is, I think that Eli doesn't need further presentation, but he's a clinician researcher in pediatric immunology, full professor at the University of Montreal, and head of the immunology and rheumatology department in the Hospital of Saint Justine there in Montreal. And he is currently the president of the CIS. And anytime that I heard him talking about in immunological reconstitution after the transplant, I actually learned a lot, and that's the reason why I asked him to give us this talk. So Eli, thank you very much for being here, and the floor is yours. Thank you very much.
Yes, no problem. Give me 1 sec that I share my screen. Yeah, this is it. Do you see it well?
Yes.
Okay, so there are some elements that I'm going to repeat regarding what has already been said by Alba and Emma. And I would like to thank you for inviting me, and I hope we'll have an interesting discussion after that. So if you look at the skin, and my talk is going to focus on skin, and then we will discuss about the other area of immunity or primary immune disorders if you want. On SCID, we had during many years no improvement in the survival, with a survival that was globally between 72 and 73% during the different decades. And then suddenly, finally, I would say, we have a significant increase in the survival, and this is due to the newborn screening. So in terms of survival, we are doing way better now, and one could ask, okay, survival has improved, but what about immune reconstitution? And is immune reconstitution important? After all, those patients were about to die and we just saved them. Why do we care about immune reconstitution? Because obviously beyond survival, quality of life is the most important aim of successful treatment. And the quality of life is going to depend on three things, basically, if we think about it. The sequela that the BMT procedure is going to induce, the evolution of the non-hematopoietic signs of the disease. If you have a patient who has an inborn error of immunity together with, I don't know, lung disease, you have to know what is going to be the evolution of that. And if the gene is not expressed only by the hematopoietic system, you can imagine that you have also issues with other things than the hematopoietic system. And obviously, the quality of immune reconstitution. We are immunologists, and we know very well that when you don't have a functional immune system, your quality of life just sucks. So let's go with and I will go fast because it has already been presented, but maybe I will give some other details. What do we know on T-cell reconstitution and B-cell reconstitution? I think that for T-cell reconstitution, and not a lot of people mention that, but it's very important to understand that there are two waves. The first wave is the proliferation of lymphocytes that are in the graft. So when you take the graft, the cord blood, the peripheral proliferation, or the bone marrow, when you take this graft, there are lymphocytes. And when you transplant, when you do your transplantation, the first lymphocyte that go out are those lymphocytes. And obviously, it will depend on the graft source. It will depend on the intensity of T-cell depletion. If you do a T-cell depletion or not, you will have more or less T-cells. And the prophylaxis of the GVH. If you put ATG just after, or if you put cyclophosphamide, or if you put Compat, it won't be the same. So this first wave, okay, and this is the complicated thing, is not good. It's not important. It's BS, okay? The real one, the real immune reconstitution is the second wave. The second wave that comes from stem cells or common lymphoid progenitor that engraft and that seed progenitors into the thymus. And this second wave is crucial for long-term immune reconstitution. And without this phase, what do we see actually? Because when I say it's BS, I'm a bit unpolite, I apologize, but what is funny is that without this second wave, you can still be alive with just the first wave. Because when there is not this second phase, what you observe is a continuing homeostatic proliferation of the T cells that are contained in the graft. And that can work for decades and decades. That is the particularity of T cells. But those are T cells that are skewed usually to Th2 phenotype and that are less functional than a true reconstitution. That said, you have patients who have been transplanted with HLA identical transplant who are doing very well with just this first wave. But we have to think, what am I speaking? What am I identifying when I see T cells and CD4 T cells at 2 months? Where do they come from? So if you look at this kinetics, this is exactly what you see on this left here on the paper from Niraj Patel and New England Journal of Medicine in 2000. Here you have the first wave in right, and it's arrow cells, and boom, it goes down. And then here you have the real good wave, the second wave, with CD45 array, because it comes with thymus differentiation. And we showed that it took 9 months to 1 year to have a normal immune reconstitution in this old paper in Blood on immune reconstitution. So what predicts a long-term T-cell reconstitution? An early T-cell reconstitution? If you have a good early T-cell reconstitution, it predicts a long one. When I say early, I mean 6 months. A good thymic input and output, both early and on the long term, and the appearance of naive CD4 T cells coincides with refunctioning of the thymus. Those are 4 important elements. On this retrospective study that we published in Blood among 332 patients with SCID, we show that with the area under curve, we show that there is a correlation between the CD4 cell count at 6 months and the CD4 cell count at 12 months with the long-term immune reconstitution that we defined that was more than 1,000, more than 500 CD4, and the PHA proliferation that is better than 50%. So you see that when you have when you look at 2-5 years, there is a correlation, and less good at 6-10 years. But just to look at the CD4 at 6 months is going to tell you how it may be later on. So is it important? Is there an impact? In this old paper, again, we showed that yes, when you belong to the group with a good T-cell reconstitution at 1 year or 6 months, then you have a better survival than if you belong to the group who has a T low or a T negative, T minus reconstitution. This paper from Benedict Neven is very interesting because she looked at the events as a function of T cell reconstitution just by, for example, the normal CD4 or low CD4. And you see here the event-free survival, the difference is huge. If you look at all events, there is a strong difference as well. If you look at just infection, HPV, autoinflammations, GVHD, and nutritional support, you see the differences. And if you see the infections with or without HPV infection, you see the differences. So as expected, the more you have a good T cell reconstitution, the less events you're going to do and the better survival you're going to have. And we showed same kind of finding in this retrospective cohorts when we looked at landmark analysis. So we began the survival curve again at 6 months, and we looked at the survival depending on the CD4 positive cells at 6 months. And we show here that patients who have more than 500 at almost 100%. And if you look at the naive T cells at 6 months also, there is a difference. But when you look at the difference, okay, we can publish it. Okay, it's significant, so cool. But are you going to decide to retransplant a patient because it is on this red here? This is more complicated, and this is where you see that we would like something more subtle to say which patient should benefit out of retransplantation rather than just waiting what happens. Even at 1 year, even if the difference is bigger, still 80% of those patients are going to survive later on. Is it worth it to retransplant them? That's a true question. Nobody has the answer, actually. So if the T cell reconstitution is so important, what are the factors that are associated with a good T cell reconstitution? When we publish that in blood, and clearly the conditioning regimen. The more you give a conditioning regimen, the better the immune reconstitution will be. In the SCID, it's very special because you can do transplantation without conditioning regimen or with just only immunosuppressive. So we made 2 groups, no conditioning or immunosuppression only versus RIC or MAC. And you see here the difference is very significant, and it's a multivariate analysis, so it is an independent. So this you can play on. And the reason is because when you do a conditioning regimen, you will induce a myeloid engraftment. And because there is a myeloid engraftment, there will be a seeding of the thymus. And because there is a seeding of the thymus, then you will have a good second wave. This is the biological reason. The other thing that went out was the genotype. And there is nothing you can change under the genotype, but we have to know that when there is an Artemis or RAC deficiency, the immune reconstitution, T cell reconstitution is way lower than for the other deficits. And the leakiness of the skin did not have any impact. So again, the influence of myeloid chimerism is very important. It goes with conditioning regimen. Here in this old paper, you see that when you have a donor myeloid chimerism, the likelihood of having very good track is higher, and it explains again by the second wave and the thymus seeding. So it's very important to consider that when you think about T cell reconstitution, you also need to think about chimerism. And when you study immune reconstitution, you also need to study chimerism. What about B cell reconstitution? During many years, I heard, who cares? I mean, you just give immunoglobulins and that's it. Come on, you save the patient who has a SCID, no T cell, now he has T cells, and you're not happy because he still has no B cell. Well, first, the kinetics, B cell reconstitution takes more time than T cell reconstitution in the context of SCID. So it's interesting, the data from Alba that you find in the literature, everybody says, and many people show that B cells come earlier, but it depends if you just look at B cells, the number of B cell function, and in SCID anyway, they come later. So it takes more time, 1 or 2 years. We showed in this paper, and Becky Buckley showed more than 2 years. And the most important thing is B cell function. We are immunologists, we know that. You can have as many as B cells you want. If you don't have T cells, your B cells won't work. So it depends on T cell function. So it makes perfect sense that when you compare the T cells and the B cells, you see that if at 6 months and at the last follow-up, still there are more patients with normal T cell function than with normal B cell function, because you need to have T cells to have B cells, and you have the patients who don't have B cells anyway. So if you look at the same question, who cares? What are the clinical events as a function of immunoglobulin substitution? Here again, the difference is dramatic. When you are under immunoglobulin, you have a lower survival than when you are not under immunoglobulin. Likewise for all the events. And again, for infection, autoinflammation, nutritional support of GVHD, and all the infection or infection without HPV. So again, those data show both for T cells and for B cells, it's better to have a good immune reconstitution. And this last paper from the group of the European group and the group of Benedict Neven is very interesting because they looked at hepatitis post-transplantation in SCID patients. And they found that when you look at those patients, everybody would say, come on, it's GVH and that's it. Well, no, they did tons of analysis, and particularly metagenomic analysis on liver histology, and they looked at by next generation sequencing the presence of infection, and they found chronic enteric viral infection. And they could show that, I read the sentence, enteric virus and infection associated with hepatitis is related to chronic enteric viral infection and immune dysregulation, and is an important risk for transplanted SCID patients with defective B cell function. The B cell function is absolutely crucial in the occurrence of those infections that induce this poor quality of life. So if B cell reconstitution is important, what influences B cell reconstitution? We could publish this in JACI and show that the conditioning regimen and the chimerism is very important. If you have no conditioning regimen, in the majority of cases, the chimerism for B cell is the recipient. And in the case it's donor, the function is good, but when it's recipient, it's poor. And when you do a conditioning regimen, you have more donor chimerism. And here again, when you have donor, usually it's good. And then you have recipient, in half of the time, it's not good. And here we observe the same thing on this multivariate analysis of 682 patients. Again, the conditioning regimen came out, the donor type, and the genotype. And here, interestingly, the genotype, if you look at the IL-7R alpha and ADA deficiency, they do better than gamma C. And why is that? It's because the gamma C have an intrinsic B cell dysfunction, unlike those guys. So to have a T cell reconstitution without a B cell reconstitution, in the situation of gamma C, you may not have a normal B cell function. While for the other one, because you have B cells from the host that can still function, just the T cell engraftment is enough. Are there more sophisticated way to assess the immune reconstitution? Everybody showed it, Emma and Alba and me, because it's sophisticated, yes, but so I won't go in the details. It was already explained, but it's very interesting to look at the repertoire. But what is more interesting is that in our papers, we show that at 6 months, we could say what is going to happen. Here, they can predict at 3 months. And you see here the huge difference at 3 months between the ones who are doing poorly and the ones who are going good. It's not statistically wow, because there is not tons of patients, but it's still spectacular. And we are waiting for the new data because they have accumulated more and more patients. And I like this image that shows you the clonality and the diversity with both the Shannon and the Simpson index. Another way to study immune reconstitution is to study exhaustion in this paper from Hélène de Calouet in CHU Saint-Justine. And she showed first that the score of exhaustion of T cells is correlated with the number of CD4 T cells. And this exhaustion score comes with is associated with the conditioning regimen. The more you do a conditioning regimen, the less there is exhaustion. And it is biological sound because, again, if you don't do conditioning regimen, you don't have the second wave. So if you don't have the second wave, you just have the first wave. What if the first wave is just the proliferation? You can imagine that it comes with exhaustion. What she showed also is that when there is no conditioning regimen, there is a correlation with time of the exhaustion score. The more you go, the more it will be exhausted. While when you do a conditioning regimen, you lose this correlation, again, which makes sense because you have a myeloid engraftment. And then there is this correlation with CD4 counts, but it's not so important. So I have told you the kinetics. I have told you how important it is. I have told you that it's better to do a conditioning regimen in the context of SCID. So now the question is how and when to assess the immune reconstitution. I think that we have to remember for any border of immunity, SCID and all the other, that when we think about that, we also have to think about chimerism. What is the chimerism? What have I done with my transplantation? Which cells have I changed? Which cells come from the donor? Both in T cells and in myeloid cells. And I put B cells and NK cells in myeloid cells because thanks to transplantation, we knew that B cells and NK cells are myeloid cells, and now it has been confirmed in the very basic paper in Nature and other that yes, actually, it's more myeloid lineage than lymphoid lineage, which is crazy when you think about it, but still. So you have to know that. And then together with that, you need to assess the T cell counts, the 3, 4, 8, array, arrow, thymic immigrants, or tracks, if you want. PHA proliferation. So there are still people who do PHA proliferation, but I still don't understand what it is used for. You have very severe patients with normal PHA proliferation, patients who are not severe with abnormal PHA proliferation. What it tells you, I don't know, you just put a bomb on lymphocytes and you see, do they respond or not? And this bomb is not physiological. So I hate this test and I still don't understand why so many people do it. The repertoire, clearly, exhaustion markers, maybe. And maybe other sophisticated thing. And if you want to assess proliferation, maybe it's better to use CD3 and CD28 rather than just PHA. And if you do with PHA, I advise you to do it with EDU by fax, so cytometry, so you see which cells are actually proliferating. We have to assess the B cell counts, the CD19, the memory B cells, more sophisticated like Swiss memory B cell, if you want, if you have access to it. But again, I don't see why it would be so important, except if it is for research. Obviously, the dosage of IgG, IgA, and IgM, and particularly IgA and IgM, if your patient is under immunoglobulin, and the response to vaccination. This is basic immunology, but remember that in the majority of cases during the first months, our patients are under immunoglobulin. So if you want to assess a patient who is under immunoglobulin with on IVIG, then don't forget the TIFIM vaccine because it's an easy tool to do, because then you can measure the antibody response to typhoid vaccination, and it won't depend on the IVIG because most of the donors are not. So what about the other inborn error of immunity? Because I spoke mainly about SCID. I would say it's the same. Chimerism is also always very important, and it depends on the disease. The assessment of immune reconstitution is the same. Although you may consider, for example, that for CGD, you are not going to pay that attention to the restoration of T cell and B cells because you've just done a bone marrow transplantation for a disorder that is more innate disorder of the polymorphonuclear, the macrophage, the monocytes. Indeed, but because you've done a transplantation, you will also assess T and B cell function, but you will be more focused on the NBT test and the DHR, obviously DHR now, and on the chimerism. And very importantly, each disease comes with its own questions, and it's the own question of those diseases are going to impact how you are going to follow up those diseases after transplantation. You are not going to follow the same thing for Riscott-Aldrich or for the NHH or for a STAT gain of function or for a combined immune deficiency. Then the question is when? Because what do you do? Okay, but when do you do? And for me, it's the most complicated question, man. Everybody goes with a guidance, and remember that guidance, it's just to guide. It's not a dogma. And someone who tell me, you have to assess at 1 year, why? I mean, maybe this patient needs, maybe this patient does not. Then if you come and say, yes, but if you want to publish something of immune reconstitution, then you have to assess regularly. Say, yeah, okay. Then that's a completely different question if you do research. And if you want to demonstrate, and if you want to draw a curve of kinetic, obviously you have to do your patient at the same time. So it's very important to consider those both aspects. I would globally consider, do it frequently. And as soon as you consider it is important. And when you see that it does not move anymore, like the reconstitution at 5 years is the same as at 10 years, I don't see why you would do every year after 10 years or after 5 years if it's stable. Remember that it's important to follow the chimerism even at long term. And when I say when it's stable, I would not recommend to get nervous and to test it all the time. But behind that, the most important thing for us pediatricians particularly, please don't make your patient lost of follow-up. And it happened to me. That's a nightmare. It's very easy to lose them, and this is bad. And we lost tons of patients because they do well. They don't want to come back anymore. They do well. So when they come back, how are you? I'm doing fine, bye-bye, bye-bye. And you wonder why you're seeing them, and then they don't come back. You forget them, and boom, bang, lost of follow-up. And then you're wondering, oh, how is doing this patient that I didn't see 10 years ago? You cannot find him or her anymore. And sometimes when you find them back, there has been a nightmare. Or you are called one day by a colleague that say, I have a patient of yours who has been transplanted 15 years ago, and now he has a GC virus infection in the brain. So, oh my God, why that? So it's a catastrophe, and it's not easy. You could say, well, but what is not easy? Just follow them. It's not easy, I can tell you, because particularly when they do well. So pay attention to that. And we must do research on those long-term ones, because I found that it's the only solution to make understand the patients that they absolutely need to come back. There is a kind of contract with the research. Contract, that means nothing, but it's a moral contract. And we have to explain them continuously that it's very important that we assess them on the very long term to be able to say to the younger ones what is going to happen when they will be 40 or 50 years old, which we don't know actually. So this is the type of recommendation. You see here this type of table. I am a co-author of this one, so I cannot say that I disagree, although I do, particularly for the proliferation of PHA, but I was not vocal enough when we wrote this paper all together. That's the problem, a paper of consensus. And you see here 3 months, 6 months, 12 months, annually, then every 3 years. This is a scheme. You can do it differently. It's not a problem. When I see this kind of table, my take-home message is, okay, frequently, particularly at the beginning, and then a little bit less frequently. And to take care of your patients, you have to know the T cells, the B cells, and how they are doing, and the rest, fine. On conclusion, I would say immune reconstitution is important, clearly. This means we need to assess it. And it comes together with a detailed chimerism. When I say chimerism, I just say blood chimerism. I'd say chimerism of the T cells and chimerism of the myeloid cells, if possible, the B cells and the morphonuclear, the CD15. No rules for frequency. I would say frequently. And the real questions are, what impacts the immune reconstitution for each patient? What is the price to pay for a good immune reconstitution? You see that with a conditioning regimen, I demonstrated you that it comes with a better immune reconstitution. So the question is, but why is that important? I suppose that conditioning regimen comes with a better survival. No, no, this is very interesting. You have the same survival between low conditioning and high conditioning, but because there is a price to pay with high conditioning, toxicity, infection, GVHD, because you induce a cytokine storm. So it's not that simple. You have to think about the price to pay for a good immune reconstitution, because you're going to give strong conditioning. So the future could be to improve the immune reconstitution other than by doing strong conditioning. So it could be non-toxic myeloablative conditioning, like antibody against CD, I forgot that becoming older, anti-secit. Thymic progenitors, like suggested by Marina Cavazzana, and I know there is a protocol soon, maybe. Other solution, like chimeric antigen receptor against myeloid cells, maybe. And those questions are actually not restricted to inborn RF immunity. It could be also questions that goes with other non-malignancy and even malignancy. So I hope I convinced you that immune reconstitution is important. I thank you for your attention.
Well, thank you very much, Eric. And Emma, could you please join me on the table? I mean, wonderful talk. I don't know if you have questions from the chat. If not, I have several ones, but please come just take a seat. And we'll come with the questions. Is there any question from the audience here in the hospital? Yes, Maria, please share the video. Yes.
First of all, thank you for the three of us for this very interesting talks. My questions are for Alba Parra. We really like your presentation, and we also think that the study of the immune reconstitution is very important in the transplant process. I have two questions. The first question was regarding the incidence of graft versus host disease in the retrospective cohort, because I had the feeling it was very high, and I wanted to ask if it was including like all grades of acute GVHD, grade 1 to grade 4.
Yeah.
because maybe it will be interesting to look at grade 2 to 4. As you know that the incidence of graft versus host disease will increase, patients with graft versus host disease will have worse outcomes regarding the immune reconstitution. This is for the retrospective cohort. And also have another question regarding the prospective cohort. My question was about the definition of the conditioning regimen. As we know, when we use myeloablative conditioning regimens, the incidence of graft versus host disease is higher, and this will also be interfere with if we have a high incidence of graft versus host disease, then the immune reconstitution will have it will be poor. So now we are trying to use either a reduced intensity conditioning regimen or reduced toxicity conditioning regimen. And I think in the prospective cohort, we didn't use myeloablative conditioning regimen because we tend to use reduced toxicity or reduced intensity conditioning regimen in order to prevent graft versus host disease and more complications.
Yeah, regarding your first question, I have collected all data of graft versus host disease, the degrees and organ damage, and also the therapy. I didn't show in this presentation, but yes, I have this data. So when we complete the study, we can show all the relation between all of them.
And moving to the second one, if you want, I can answer. We're waiting to sit with you and check what MAC means, because we were just reviewing the presentation yesterday, and probably some of those who were considered as MAC as reduced toxicity, as you were saying, so that will be adapted. And my feeling, and I do need to recheck that, because I was also surprised by the data on GVHD, despite I was working with the presentation with Alba yesterday, is that there was a problem with the colors. And it yes was no and no was yes. But I do need to recheck that, and that probably fits more with your clinical practice. So I'll check on that. Yes, Eli, go ahead.
Yeah, but it is published that when you give more conditioning regimen, you increase the GVHD.
Yep.
So it is not that surprising, although it's not for all the disease and all not. It depends which type of conditioning you compare to which other type of conditioning. If you compare MAC and RIC, this is not so obvious. If you compare MAC RIC to no conditioning regimen, this is obvious. You will have more GVHD.
Okay, I think that Christina had a comment. Could you please give her the micro? Thank you. Just a second, because they will be able to hear you better. Yeah, go ahead.
Probably you classified GVHD, yes, all grades of GVHD, and maybe there are many patients that is grade 1 GVHD, and most of these patients mainly only have topical treatment or for skin or so on. So I think it's important to split in grade 0, 1 to 2 to 4 GVHD. But my question is regarding the retrospective cohort that you could say that immune reconstitution was mainly achieved at 9 months. Have you followed patients after these 9 months? Have you collected infections problems or other immune problems after these 9 months? I think that clinically that would be very useful.
Yeah, I collect all this data. Yeah, the infections, treatment, complications.
After what we say immune reconstitution.
Yeah.
Okay, that would be very useful.
Yeah, we have all the data. I mean, this was just preliminary results that we wanted to share with all of you. Obviously, they need to be worked with your team, mainly in terms of the definition of some conditioning, but we want to see what an appropriate reconstitution means. It's not only a number, but as you were saying, what happens from a clinical perspective to those patients, and then we will have this data.
Yeah, because for example, and Dr. Haddad showed us that, or I think he showed us that we have many patients that maybe you don't have B cells, but they have immunoglobulins and they don't have infections. So things like that, it's important to.
Yes, we'll
Maybe you can comment on that.
Yes, it's absolutely evident and obvious and important that it goes with the clinical things. Just to assess the immune reconstitution per itself is not very interesting, but it's not easy to demonstrate the link between the absence of immune reconstitution or the low immune reconstitution and clinical impact and clinical outcome. In our huge cohort of SCID at the PIDTC, so we are now 49 centers in North America, we can find that it comes with autoimmunity and infection, the poor immune reconstitution. But you are going to say this is not surprising. We are immunologists. We know that immune deficiency comes with infection and autoimmunity. And it does. And it's important that to show that also after transplantation, because then it explains why we want to pay the price again for the good immune reconstitution. And this is complicated because when you want a good immune reconstitution, you are targeting the future, but you are taking risk now for your patient. The GVHD, it's now. The toxicity, it's now. So it's very difficult to consider, and that's the reason why we need those big cohorts to be able to demonstrate the things. And the other aspect is that usually when you do study and you mix in the big bag all the inborn errors of immunity, I don't think that it helps to draw interesting conclusions for the patients. We have to separate the disease by disease, even more than that, the genotypes by genotypes, because we show when we group the SCIDs that a SCID transplantation for Artemis, it's not a transplantation for gamma C, and both patients have a SCID. So imagine if you put the SCIDs with even other disease. So that's the reason why we have to group our efforts and work together. And the next level will be to group North America and Europe, because it's two huge cohorts, and bring them together will help to do very, very, very things, although it's very complicated. More because of practical things like mixing two registry than political things. Politically, everybody agrees, and there is way less ego than 20 years ago, and it's way easier to work together with the two continents now.
Just a comment on our work. What we were, I mean, we fully understand that we will not get strong data from a single center. I mean that's true. But what we were trying to see in our retrospective data is how we were doing things and what these new techniques could add to our management. So at the very end, it's true that Alba has all the data. She has all the data in a separate way. For sure, we will not go to genotype, but we will do for SCID and non-SCID, and this data will be shown. We just wanted to shorten the presentation with that, but we'll do it. But at the very end, we will not get a robust conclusions on that. We just wanted to check what we were doing. We are highly interesting on the final outcome of those patients in whom our colleagues from the stem cell transplant group said we want to withdraw them from immunoglobulin replacement therapy despite they didn't fulfill all the criteria. We want to see if that takes an impact or not, and probably it doesn't, because we have been checking that. And at the very end, the reason for that is maybe that we don't know the criteria, and that's a question for you, Ellie, on when to stop immunoglobulin after transplantation, because it's something that we all want to know. But if you go to the guidelines, it's not there, and probably you don't need to fulfill all the criteria, and you see that B cells is enough, IgM is enough. So I don't know, and that's something that we want to check instead of saying, hey, this thing is not up to the protocol. At the very end, we want to know, is it good enough? Because I mean, is it reasonable or not? What's the final outcome of the patient? So how do you manage to withdraw patients from immunoglobulins?
First of all, a comment on what you say. This is very, very important, and it is crucial for each center to do exactly what you did, to have a retrospective data of your own center, because you have to follow what you do, and this is crucial. I was not saying that it was not well or not important, obviously. Your question about when do you stop immunoglobulin, I am going to answer something that I don't do in my center, because in my center, because we are mixed with the transplantation for malignancy, they say, you know what, Ellie, when you came with your rules, you put a total mess, and then we don't know anymore who does what, and it's a total mess. We need rules, and we need everybody has the same. So when you begin to say everybody should have the same, you understand that, okay, then you take the minimum risk, and that's it. So the first way to do is to do like that, like everybody the same, and you stop at this date and then you follow. The more biological and clinical response would be for each patient when we do no precision care. So that's what we should do. You look at the number. First, you look at the T cells. You look at the disease. If it's a SCID with no B cell, okay. If it's a RAG deficiency, if you don't have an engraftment of B cells, I mean, don't stop immunoglobulins. I mean, I can tell you how it's going to happen when you're going to stop. So you have to look at the disease. You have to look at the reconstitution, the chimerism. You have to look at the T cell function. Is the T cell function normal? If the T cell function sucks and is terrible, don't stop immunoglobulins. You are facing a combined immune deficiency. It won't work. And even if it works, it's dangerous. You have to look at if your patient has GVHD and did get a splenectomy or not, because in that case, you should not stop. If you have a good T cell function and your patient is still under immunoglobulins and you wonder, well, maybe I should stop, then the best way to do it is first to look at IgA and IgM. If they are at 0, not very logical to try to stop, although you can still try. If you begin to see a rise, then you can stop. And then the most important thing, if you stop immunoglobulins, is to follow up. You can make a mistake by stopping them. It's not a terrible mistake if you follow the patient and you bring it back to immunoglobulins. If you see that IgG don't increase, or if you see that the response to vaccination is like you inject tetanus and you see nothing, you should put your patient back to immunoglobulin. But then it becomes back immunology, and immunology should take back those patients from the transplanters, actually, because the transplanters don't know well how to deal with chronic classic immunology disorders. And it becomes a new immunological disorder, which is called the post-transplant immunological disorders, but it follows the same rules as another immunological disorder. So me, I follow IgA and IgM, then I stop, then I pay attention, I look at the vaccination, and if everything is okay, I continue to stop the immunoglobulins. But I have seen cases where the immunoglobulin has been stopped because, you know what, that was the protocol, then they stopped. The IgA and IgM were 0, and you know what, the patient did well. Progressively, the IgA and IgM increased, and the patient never had issues. And I realized 2 years later that the immunoglobulin shouldn't have been stopped, but that was okay. So it's difficult to have rules that work in all circumstances, but it's better to have rules to have a quiet mind and not to worry all the time.
That's what I meant. Thank you.
I hope I answered. It helped to answer your question.
No, that's great. I have another question at the very end, but Laura Alonso was, no, is it ready? Andrea, do you have a question?
Yes, well, congratulations for all the presenters. And I want to ask to Emma, because thank you very much for your talk. To have the repertoire in a hospital is very useful, and we are very happy because I'm a pediatric immunologist. And do you think this is now a routine tool that we have now and we can ask in all the patients we think is useful, or is a tool that are in a study or in a pre-doctoral research, or what do you think? We are prepared to ask for this tool like a routine tool, or what is your recommendation?
Yes. In the case of the T-cell receptor sequencing, we have validated the tool in the laboratory and implemented it, and we are ready to use it in clinical issues. And the other strategy, the B-cell receptor, is still under development, and we are validating it.
Perfect.
But we need to pay it.
Yes.
Don't forget it. So it's quite different. As many, it's not clinical practice. I know what Andrea wants to do with therapy ABC1 and so on, these patients pre-transplant, and we need to pay for that. But just related to your comment, it's true that to date we need to pay it, but it seems that from a technical point of view, it's feasible. We are eager to see when a B cell BCR is ready, because we want it. But when we start doing that, our colleagues from the transplant told us, hey guys, but don't draw more blood from our patients. I mean, they're small, they are cytopenic, so that's a problem. So Alba, moving from the lab to the clinical practice, how have you managed to try to diminish the volume and the tubes and so on? So is it feasible in terms of clinical practice? Is it a problem for patients?
What we done was to optimize this blood volume and be able to analyze all the immunological parameters from the same blood tube, rather than each test being associated in the different tubes. So to perform the TCR and BCR repertoire, it's not necessary to take more blood volume and an extra test, analytic test in the patients.
Okay, that's good. And if there are no further questions, I have a last one for Ellie. I mean, you talk about TIFIM, Salmonella TIFI response after vaccination. Our feeling, and we are not using that after transplantation, but yes, in the assessment of IAI patients, is that it's not that robust. And the main problem with that is that basal value is just below 7.4 or something like that, at least here in Europe. And I don't know what it means. I don't know if it's 0 and I don't know if it's 3. So at the very end, when they say this, you got to have a full 4 increase, I don't know what it actually means, because it probably comes from 0, and I don't know if 8 is positive or is negative. So I have some problems in understanding how it works. How do you manage with TIFIM?
I don't know. I don't use it a lot. I have used 1 or 2 times, and I did not know what to do with the response. But maybe I should remove that from my slide, actually, because it's other people who say that we should use it, but I don't have the practical aspect. I don't know how to answer your question.
I mean, the feeling is that it's not as good as we thought when we started working on that. But it's true. But it's true that it offers a window of opportunity in those patients in whom you are not comfortable in stopping immunoglobulin replacement therapy without checking something. Okay, I think we're done. We're on time. I mean, those were great talks, Ellie. Thanks again for being here. We'll keep in contact. Emma, thanks a lot for this wonderful job you're doing, also for Alba. Now we have time for a short break. We'll be back at 5:10, so we'll be strict on that because we have our attendees online. So again, thank you very much and see you now. Bye, Ellie. Thank you.
Bye-bye.
Take care. Bye-bye. Noies, excel·lent presentació, molt bé. Doncs Alba, jo crec que ho hem de revisar. M'ha donat la sensació que el problema no és els colors, perquè no pot fer un 77%.
Hello. Hello. Can you hear me?
Hi, Emma.
Hi, can you hear me?
Yeah, we are actually doing the break.
Ah, okay.
In 5 minutes, we're back. Okay.
Okay, perfect. All right. I was a bit worried I was late. I was struggling to
Hi.
join.
Hi, Emma. This is Peran. Great to hear
Hello,
you.
darling. How are you?
We're back in 5 minutes, okay?
Okay, no problem.
See you now. Take care.
Bye.
Vigila que a la segona fila se queda trancada. Sí, vigila. Hay que hacer las pruebas todas, trancada, total. Hay que cambiar y adaptarse. Vamos allá. Joder, no, la verdad es que estoy bloqueando. Jo m'anava a posar a la segona fila i la segona.
No, en los casos, yo me porto. Laura. So, Andrea. So, yes, so we're back and we move to the third roundtable that will be chaired by Laura Frogs from our center. I hope that you are all back. We are more than 100 attendees between the ones here on the hall and those online. So thank you very much for being here. Now we have the last talks and at the end, the testimonial video that I mentioned before. So Laura Fox, thank you very much for sharing this talk.
Okay, thank you very much for the invitation to participate in this meeting. That is quite interesting. And now we are going to start with the with this table that is about transplantation in adults with inborn errors of immunity. And for this, we are going to start presented Professor Emma Morris. It's an honor to come with you. She's a consultant of hematologist at the Royal Free Hospital and also director of the UCL Institute of Immunity and Transplantation. So I don't know if you are with us.
Hello. Yeah, can you hear me and see me?
Yes.
Well, not see
Can
me,
you
but
see my slides?
not
We are
yet.
next.
We're getting there.
I'm supposed to be screen sharing. Can you see them?
Yeah, but we see
the other
slides,
screen.
but not the presentation.
Probably it's the other screen.
Pardon?
Maybe it's the other screen because we see the.
Oh, you don't see it. Hang on a minute. Sorry. Oh, it worked all right in practice. It's always the way, isn't it? I'm sorry. Let me just see.
There you are.
Now you just need to put it on full
Yeah.
screen and that's done.
Is that okay?
Now it's perfect.
Ha!
Go ahead.
Brilliant. Okay. Thank you very much, everybody, for inviting me. I'm sorry I couldn't be in Barcelona. I'm in London and it's just started raining. But it's a real pleasure to speak to you. And I apologize if any of you were at EBMT, because this is very similar talk to the talk I gave last week in Glasgow. So I'm imagining you're all immunologists, so you don't need an introduction to inborn errors of immunity. But just to say that the comorbidity of these diseases in adults is significant and accrues over time. So I think one of the really important things to mention when we talk about using stem cell transplantation for adult patients or older adolescents with inborn errors of immunity is many immunologists are worried about the risk of transplantation, and many transplanters are worried about the excess comorbidities of patients with inherited immunodeficiency. But I just want to really highlight the fact that for patients, I'll just get my laser pointer up, sorry. For patients with inborn errors of immunity, their life expectancy with conservative management alone is extremely poor. So you see here for patients with complex CVID or granulomatous common variable immunodeficiency, their chances of being alive beyond the age of 30 are less than 50%. Likewise, for patients with some of the more common, in inverted commas, combined immune deficiencies, the chances of surviving into adulthood or into beyond middle age with these diseases with conservative management alone is very poor. So I just want to put in your mind that these are serious diseases that result in premature death and a significant burden of disease in early adulthood, and that these patients warrant an attempt to offer them a curative therapy. Now, many of you, I'm sure, are pediatricians and will be familiar with the fact that allogeneic stem cell transplantation is a gold standard therapy for many inborn errors of immunity. For example, here, these are some very recent survival curves for patients with ADA SCID who've been treated with allogeneic transplant. In the middle, these are patients with Wiskott-Aldrich syndrome from a recent EBMT series published just a year and a half ago, again with excellent overall survival. And on the right, this is a European cohort of 700 patients who had allogeneic transplant for chronic granulomatous disease. So most people don't question the role of allogeneic stem cell transplantation in infancy or childhood. And I also just want to highlight the fact that obviously in the SCID patients, the majority of these have the majority of the patients have their transplant extremely early on in life, often in the first few weeks. But for combined immune deficiencies or CGD, for these series, the median age at transplant was 5 years or under. So these are very much pediatric series generating excellent outcome data. But not all patients with severe inborn errors of immunity are transplanted in infancy or childhood. Sometimes that's because they've not been diagnosed, they may have had an atypical presentation or presented late due to confounding genetic, clinical, or environmental factors. For some patients, they've only recently been diagnosed with an inborn error of immunity, having had genetic investigations. And for other patients that we see who are referred to us in late adolescence or early adulthood, they were known to have a potentially transplantable inborn error of immunity earlier on in life, but at the time there were no appropriate donors available. And we also have to bear in mind that for patients in their early or mid-20s, the kinds of outcomes for transplant 20 years or 15 years ago for matched unrelated donors or haploidentical transplants were far inferior to the results achieved with sibling transplants. So at that time, many parents were counseled not to proceed to allograft if a sibling donor wasn't available who was unaffected. So when should we consider transplant in adults with inborn error of immunity? Well, the sort of throwaway remark is when patients have demonstrated a severe clinical phenotype, but actually before they have developed too many complications. This makes obvious sense as a clinician, but actually it's extremely hard to identify these patients. And it's particularly hard to do that in patients that you've looked after for many years, because you tend to just see a very gradual incremental deterioration in their health. And sometimes they then subsequently develop a rapid deterioration, or over time they've developed progressive end organ damage almost in front of you. And when you do decide to transplant, you realize that it's too late. Some of the guides we use to trigger referral for discussion about transplant are recurrent or one serious life-threatening infection episode, the presence of bone marrow failure, refractory or poorly responsive autoimmune or autoinflammatory diseases, often requiring multiple lines of immunosuppressive therapy, a malignancy associated with their inborn error of immunity, typically a B-cell lymphoma or HPV-associated squamous cell carcinomas, and patients with HLH. So as physicians, either as an immunologist or as a transplanter, we have to understand the complexity of this cohort of patients. And there are very many things to take into consideration, including variables relating to the patient and their underlying disease. And I think the biggest challenge is for patients with recently described inborn errors of immunity or particular diseases where there are very few described patients worldwide or in the literature, where the natural history of this disease or this particular genetic defect is not very well documented, or their future with conservative management alone is unclear. We don't have very many long-term follow-up studies. And in some families, there's evidence of incomplete penetrance or phenotypic heterogeneity, which means identifying when is the right time to transplant a sibling if another sibling has been severely affected at an earlier age, or you have an older sibling who's got the same genetic defect but remains well, makes these decisions about the risk-benefit of transplant very difficult. In adult immunodeficiency patients, we are beginning to identify more and more genetic variants of uncertain significance. And even if these patients are symptomatic, essentially there is a requirement, or in an ideal world, a requirement to demonstrate that that variant of uncertain significance is actually disease causing, and that usually requires a number of complex laboratory-based functional experiments performed, usually in research laboratories, and of course this is time consuming and not possible for all patients. There are also a number of variables relating to the transplant itself, and essentially these aren't any different to variables for any other patient an adult transplanter would consider, including patients with hematological malignancies. I think I would like to highlight, however, that it's only very recently that we have been building a body of published evidence on outcome for adults who've undergone allogeneic transplant for immunodeficiency. But we have to be cognizant of the fact that there's also a changing therapeutic landscape, and there are a number of targeted therapies available now for some particular monogenic causes of immunodeficiency. And finally, I think it's fair to say that the comorbidities associated with inborn errors are typically very different to those associated with prior chemotherapy on multiple occasions for patients with hematological malignancy. So my colleague Siobhan Burns, who some of you may know, who runs the clinical working party of ECID, she's an adult immunologist who works with me. She and I put together a How I Treat publication for blood 3 years ago, where we discussed how we assess and manage patients who've been referred for allogeneic stem cell transplant who have inborn errors of immunity. And what we identified were a number of factors that relate to the patient and their comorbidities, and to the transplant itself, and the presence or absence of any literature, which help us decide whether we think the transplant is relatively low risk and high likelihood of benefit, or whether it's high risk and or low likelihood of benefit, or indeed not indicated. So about 5 years ago, we presented, well, in fact, it was before that, we presented a very small series of adult patients at the ECID meeting when it was in Prague, I think in 2016, who'd undergone allogeneic stem cell transplant in our centre over the preceding 10 years. And we subsequently increased that cohort to 29 and published them in Blood. And actually, this was a real game changer for me and my clinical practice, and probably my academic career, because I'd been very much involved in hematological malignancy transplants and genetic engineering of T cells for hematological malignancies. And at that time, we demonstrated that for this very small cohort of adult patients, that we could achieve really excellent outcomes following allogeneic stem cell transplant. And this was the biggest series that had ever been published, despite being extremely small in retrospect. but it changed, began to change clinical practice, certainly in the UK. And it took us about 2 or 3 years to persuade our National Health Service to actually fund and commission allogeneic transplant for inborn errors of immunity, because prior to this, funding was only available for transplant for patients under the age of 18. And as a result, since then, from having just transplanted a handful of patients, we now run about 7 clinics a week, 7 clinics a month, run twice monthly international MDTs to discuss these patients, and have now transplanted over 90 adult patients with inborn errors of immunity in our service. So just to go to discuss some of the outcome data, this is a retrospective multi-center study that I led with Michael Albert, who's a pediatric transplanter based in Munich. And this was on behalf of the Inborn Errors Working Party of the EBMT. And we were able to identify 329 patients who've been transplanted for inborn errors of immunity over the age of 15 at the time of transplant. So this made us aware that quite a lot of this practice was going on across Europe and indeed across the world in very small numbers across many centres. And these transplants occurred in over 50 transplant centres. And we were very pleased with the results, because we were essentially able to demonstrate that the overall survival for these patients was really quite acceptable considering their comorbidities. And for patients in the green line who were classified as phagocytic defects, the majority of these had chronic granulomatous disease. Some of them had GATA2 deficiency, and the patients in the red line with combined immune deficiencies did very well at a median follow-up of 3 years. We were able to demonstrate that the inborn error of immunity subgroup was statistically relevant in terms of impact on overall survival and event-free survival, with the CGD patients doing better than the patients with combined immune deficiency. And the patients doing worse were those who were allocated to the predominantly antibody deficiency group, which contained patients with common variable immunodeficiency. One of the really important findings from this study, however, was that your age at transplant did not significantly impact on either your overall survival or your event-free survival. But the factors that really were important, other than the type of inborn error of immunity that you have, were the number of complications associated with your immunodeficiency at the time of transplant. And this impact both overall and event-free survival. When we look in more detail at this group of patients, you'll see that the majority of them had matched unrelated donors or mismatched unrelated donors. And we were able, I won't go through this in detail because you can look the paper up, but we were able to identify a number of factors that really adversely affected overall and event-free survival. And those included hepatic comorbidity, splenectomy prior to transplant, evidence of bronchiectasis, and an elevated HCT-CI score. We also looked at a number of different immunodeficiency associated factors that we thought would be relevant, which turned out not necessarily to be so. And when we look at these factors in more detail, you can see that, as I just explained, the things that really are impactful are hepatic comorbidity in terms of overall survival and event-free survival, with patients with significant liver disease doing really badly post-transplant, and patients with established bronchiectasis and poor gas transfer doing badly post-transplant. So in an ideal world, to really understand whether our patients can benefit from transplant rather than is it actually feasible to do it and can we get them through it safely, is to do a prospective randomized control trial. And of course, this is extremely difficult in rare diseases. So we went some way towards getting some useful comparative data by teaming up with our colleagues at the Necker in Paris and doing a case match control retrospective study. And we identified 79 index transplanted patients with immunodeficiency who were 15 years or older at the age of transplant. And these were patients who were transplanted either in Paris or in London. And for each patient, they had up to 3 case match controls who had not been transplanted. They were matched for the era of diagnosis, the age, for their immunodeficiency subtype, and the number of immunodeficiency complications. And our entire cohort was 281 patients, with 202 in an untransplanted case match controls. And what we were able to demonstrate in this study is that the patients who underwent allogeneic transplant achieved a plateau and disease-free survival, where the patients who didn't undergo transplant, who continued with conservative management, had disease progression over time. And this was also represented, as you would expect, with the number of cumulative associated events, which continued to accrue after time in the patients who weren't transplanted. You'll note here for the patients who weren't transplanted, there were obviously transplant-related events that happen earlier on, but then these patients plateau. So we saw a very significant improvement in disease-free survival and inborn error-associated events or complications. However, because of the higher than expected TRM in the transplant group, because a substantial number of the Paris patients had undergone myeloablative transplant, this particular study didn't show a significant benefit in overall survival. But it does provide tantalizing data, I think, to suggest that there is a significant impact in terms of disease control if you can select patients who survive transplant well. And I come back to this at the end because I think patient selection is really the key, probably the single most important factor in determining outcomes in this cohort of patients. So I'm just going to spend a few minutes describing our not quite total, because we've now done 90, but this was the most recent analysis that has been put together by my colleagues Tom Fox and Valerie Massey. Valerie came over as a clinical fellow. She works with Eli Hadid in Canada, and Tom has worked with me for a number of years at UCL. Some of you may know him. And so this is data on 82, so this is single-center data on 82 adolescent and adult patients who've been transplanted. The median age at transplant for the whole cohort was 21 years, but you'll notice that the oldest patient we've transplanted to date has been 59 years. We calculated in these patients their HCTI scores, and we also calculated their IDDA score. So this is the immunodeficiency and dysregulation activity score that was devised, is probably the right word, by Marcus Seidel to try and develop a scoring system to evaluate disease activity in patients with primary immune dysregulatory diseases such as LRBA deficiency and CTLA4. And the reason we wanted to evaluate this in our transplanted cohort was to see whether it can provide additional granularity and predictive capacity over and above the HCTCI score, which is a fairly crude score, because there's 22 different variables which are scored from 0 to 5 in the in the IDDA score, which takes into account various immunodeficiency specific, autoimmunity specific, and autoinflammatory complications. On the right-hand side here, you'll see that we broadly had just over a third of our patients had phagocytic defects, a quarter of them had CGD, and various other combined immune deficiencies and immune dysregulatory disorders. So we split our cohort into 35 adolescents who were between 13 and 18 years at transplant, and 47 patients who were greater than 19 at the age of at the time of transplant. And I think the only thing really to comment on here is actually that both the CTCI score and the IDDA score didn't significantly differ between the groups. We did have similar numbers of matched unrelated and mismatched unrelated donors. We used more fludarabine, melphalan, and campath conditioning in the adults. We are beginning to move to fludarabine and triosulfan-based conditioning in the adults, but trio wasn't available until recently to be prescribed in the UK for our adult patients. So these are our data for this cohort of 89 patients with a median follow-up of 35 years. This is all the patients we've ever transplanted up until the ones from the last year. And our overall survival at 3 years is 90% and event-free survival 72%. When we, and I guess this is this smacks of data massaging, but the reason we have then looked at our cohort of 74 patients since 2010 is that that was the time when I started doing joint BMT clinics with the immunodeficiency immunologists, and we started working together to run this service, which I think really helped with patient selection. It helped me learn about the underlying immunodeficiency and what was likely to happen with conservative therapy alone. And it was also helped the immunologists understand what are the appropriate indications for transplant. And we have achieved really good overall survival. Remember that the oldest patients here are up to 59, and our longest overall survival is 18 years. We don't yet see a statistical difference in both event-free survival at the bottom or overall survival when we split our patients by age into the adult over 19s and our adolescent cohorts. So we did look at the IDDA score pre and post transplant. So this is a measure of immunodeficiency and immune dysregulation. And we can see very clearly that transplant, beyond 12 months post transplant, we see excellent resolution of immune dysregulation and immunodeficiency. We see really good response in terms of inflammatory colitis for patients who have immunodeficiency associated colitis at the time of transplant. And we also see a significant reduction in recurrence of infection. So we've spent a bit of time, and if anyone was at EBMT in the Inborn Errors Working Party session, there were 3 different talks that had tried to evaluate the IDDA score in different transplant cohorts. And what we have been able to demonstrate is that we can identify, if we divide our patients into 3 separate IDDA score groupings, so low score, medium score, and high score, that this does indeed predict for overall survival and event-free survival. Now, my first response to that was, when the team showed me this data, was so what? Because that's a really difficult score to work out. It takes a lot of time. You've got to look at lots of different parameters. And actually, the HCTCI score is really simple to calculate and looks as if it separates a good risk and a poor risk group out. And data I haven't got here, but which we're including in our draft manuscript, and which Tom Fox presented at EBNT, actually identifies that some patients who have a low HCTCI score actually have a higher IDDA score, and we're inaccurately predicting their overall and event-free survival. So we're just doing some further statistics on that. So I think there will be a benefit in using the IDDA score to really refine our outcome predictions and assist with our decision-making for these patients. So we're nearly at the end now, and this is a slide of one of my patients with his permission who underwent transplant for DOC8 deficiency just over 5 years ago now. And one of his red flag indication for transplant was the fact that he'd had 2 prior squamous cell carcinomas resected associated with HPV on his scalp and his forehead, and he had these very significant warts. They were confluent across the soles of his feet and all over his hands, and they were so prominent pre-transplant that he was he'd never had a job. He hadn't got through a job interview. He couldn't use a mobile phone because he couldn't use a touch screen, and his quality of life was appalling. He underwent fludarabine, melphalan, Campath, so T-cell depleted transplant, and as expected, but I think worse than I had expected, his warts flared very significantly just after we began weaning his immunosuppression. So he'd had a little bit of grade 1-2 skin GVHD, and we kept his cyclosporin on for longer than our usual 3 months. And during this time, his warts had progressed quite significantly. So we promptly withdrew his cyclosporin. Fortunately, he didn't have a flare of GVHD, and he went off again. And when he came back to clinic at a year post-transplant, actually, I was horrified because his hands and his feet were appalling. And he was pretty devastated because he'd been through transplant. He really thought it was going to have made a difference. And I just looked at him and I said, I don't really know what to do. I'm very sorry. You know, on paper, your T-cell and NK cell immunity looks good. You've got decent T-cell proliferation. You've got normal numbers of subsets. And then we tried some imiquimod, and he had the Gardasil vaccine. And then gradually over time, he saw amazing resolution of these warts that he'd had for his whole life. And when I saw him just before Christmas in clinic, and I don't know how well it magnifies on your screen, but his hands are completely clear of warts, and his soles of his feet have entirely resolved. And he was so delighted. He'd always been a really shy guy who never really made eye contact. And he just walked into the clinic room and gave me a massive hug and described to me in great detail how he'd just been on holiday and had sat on a beach. And it's the first time that he'd ever done that. So for me, that felt like a bit of a success. So in my head, he's kind of a poster boy for our transplant program. So just as we finish, it's important to say that there are alternatives to allogeneic transplant for some inborn errors of immunity. There are targetable defects, and we can use drugs like abatacept for patients with CTLA-4 insufficiency, PI3 kinase delta inhibitors for APDS patients, JAK inhibitors for patients with defects in the JAK-STAT pathway. However, our experience with those clinically in adults is that they're rarely sufficient to completely reverse the clinical phenotype. And of course, they're not curative. And the durability of the response is unclear, and the therapeutic window and toxicity of the treatment is variable between patients. There are some gene therapies available and effective for ADA-SCID, XSCID, XCGD, and WISCOT, where, of course, there's no risk of GVHD, and they're available for patients without a donor. However, at the moment, there are really serious issues around access and cost issues in the absence of a number of clinical trials. And for some of our patients who are very long-term post-gene therapy, the degree of correction can be variable depending on the underlying immunodeficiency. We and others in the lab are developing gene editing approaches to try and correct the mutations in situ, and allows tight regulation of the genes under the control of their endogenous promoters. And these are both making their way into clinic all the time in the form of phase 1 clinical trials. So my conclusions and recommendations are that reduced intensity transplant is safe and effective at resolving clinical features across a range of inborn errors of immunity in older patients. Patients with high HCTCI scores secondary to lung and liver disease have an increased risk of adverse outcomes. The IDDA score can predict both overall survival and event-free survival and needs to be evaluated in larger cohorts. I really, really, really recommend working closely with paediatric transplant colleagues who have by far and away the most experience of transplanting inborn errors of immunity, but also working really closely with adult immunodeficiency immunologists who understand the natural course of the disease without transplants. We run an international adult immunodeficiency transplant MDT, where we discuss patients every second and fourth Friday. And I know some of you have had patients that you've discussed at these meetings. You're very welcome to contact me and discuss patients. And the group of people who join the MDT meeting are a mixture of transplanters and adult and pediatric immunologists with an interest in the area. So finally, obviously, I haven't done all of this on my own. I get to give the nice talks and sometimes go to nice places, but I'd really like to acknowledge all of my colleagues and the amazing team that I work with here in London. So thank you for that.
Thank you very much, Dr. Morris. It's been a great presentation. We will leave the questions for the end of the sessions. And now I'm going to send Dr. Laura Alonso, consultant of hematology and oncology at the Vall Hospital. She's especially focused on pediatric transplant.
Okay. So thank you very much for inviting me. I have just learned that the table is called Transplant in Adults, but I'm talking about the pediatric experience. We, in our unit, we treat patients from the newborn age until the age of 18. So, okay. So I have looked at our database and we have 918 allogeneic pediatric transplants registers. That's from the 80s and until December 2023. Of these 918 transplant procedures, 126 were performed for the dedication of an inborn error of immunity. And that's in 126 transplants in 112 patients. That's 14% of the cohort. I have to say that although congenital dyskeratosis and Schwarzman diamond patients are now included, are now considered inborn errors of immunity under the classification, we have these patients registered as indications for bone marrow failure, so they would not be included in the numbers. So the numbers of patients according to the time period, so until 1990, 3 patients received a transplant with us. And then you can see how the numbers have increased across different decades. And from 2021 until 2023, we have now performed 17 of these patients. And we will, a bit later on in the talk, we'll look a bit more in detail at these numbers. So the donors, a quarter of the donors are HLA identical family donors, most of them matched sibling donors, although I have included here some HLA identical parents. 46, the next big cohort is for the unrelated donors that comprises 36% of the patients. The haplos are the smallest part of the chart, and that's 10% of the patients, that's 13 patients. And if we split, depending on the decades of transplant, we can see that the first 3 patients who received a transplant all were transplanted from family donors, either HLA identical or haplos. And then after that, we have seen an increase in the unrelated and in the core transplants. The haplo transplant didn't increase as much and remained in low numbers. But now in the last few years, with the new platforms of transplant, we are seeing an increased percentage of patients transplanted from haplo donors. when we look at the age of the first transplant, so you see most of them, more than 85% of the patients receive a transplant in the first 5 years of age. 42, sorry, that's total number, not percentages. So 42 in the first year of age and 43 in the from 1 until 4 years of age. Patients 10 and above, so 10 until 18, we have 13 patients. And when we look at these 13 patients, you can see that six of them, so half of them, were transplanted in the last 4 years. So until 2021, the numbers of older patients were very low. So then if we look at the baseline diagnosis, SCID or non-SCID, we can see, do I have it? See, that the SCID cohort has remained fairly stable across decade, like from 10, 12 patients per decade. And however, the non-SCID have increased. So you can see the orange lines are the non-SCID patients, and we can see how they are increasing. Because some patients were transplanted many years ago, there are some patients for whom the definitive diagnosis was not available. Okay, that's few patients. So the non-SCIDs, according to the international classification that we have transplanted, we have some CD40 ligands, some combined immune deficiency with syndromic features, HLH, and that the cohort that is probably now increasing more is the effects of the phagocyte number with the chronic granulomatous disease. Okay. 14 patients, so there was 126 transplants in 112 patients, so 14 patients received a second transplant. The baseline diagnosis were variable. I'm sorry for the typo in the last diagnosis. Of these 14 patients, 11 are alive and 3 died. And what happened? So what kind of donor had been used for these patients? So 8 patients had received an unrelated donor. Of these 8 patients, 6 of them then received another unrelated donor, and 2 of them were rescued with a haplotransplant. Other 5 patients had received first an unrelated cord blood transplant, and then of these 5 patients, 3 received a second transplant from an unrelated donor, and 2 of them received a second transplant for another unrelated cord blood unit. Sorry, and one patient. This is one patient with a leukocyte adhesion deficit, had received a transplant from an identical father, and then the second transplant was used from the same donor. And these transplants, the 14 second transplants, were most of them performed from 2011 until 2020. The patient outcomes. So 76% of our patients are alive and 27 sadly died. The causes of death were varied, GVHD, viral infections, different organ failures, and one patient developed refractory autoimmune hemolytic anemia and sepsis. I quite like this slide. I like this slide quite a lot because this shows the survival status according to the transplant period. So in blue, you can see the total number of patients that receive a transplant. You can see how this was increasing across time, but in orange, you can see the patients that died, and you can see that the death rate keeps dropping. And in the last 3 years, from 2021 until 2023, 17 patients have received a transplant in our unit, and one of them died. So I like how this survival rate keeps increasing. So what has changed? So we can see this improvement. So I think it's a lot. Many variables have improved. So we can see this increase in the survival rate. The pre-transplant management, the neonatal screening for SCIDs, the supportive therapies that has been already commented for non-SCIDs, and depending on the transplant process, donor selection, manipulations of the graft. And the new platforms of manipulation are making transplant more accessible with less morbidity and with less associated morbidity and mortality. So the balance of risks versus benefits goes in favor of transplant for an increased number of patients. The management of viral infections, it has been commented, but the availability of CTLs, of specific antiviral T cells, has changed our management, and also we'll see the place of letermovir or specific immunoglobulins for CMV. We have seen huge improvements in the management of GVHD with more drugs available, and also the management of the endothelial complications. We now have available the fibrotide, and also for patients that might develop thrombotic microangiopathy, we now have available eculizumab. So this has changed. And also the participation in collaborative studies, which help all of us understand the problems that we might face. So neonatal screening for SCID is available in Catalonia since January 12, 2017. Of the more than 100,000 newborns screened, 8 had been diagnosed with SCID until December 2023. 2 of them didn't go for transplant. 1 went for gene therapy and 1 went for thymus transplant. And there is now another patient who is diagnosed with Artemis deficiency that is in the process of receiving gene therapy. And 6 patients receive a transplant, 2 matched sibling donors, 1 haplo, and 3 cord bloods. Of these 6 patients, 1 sadly died of refractory hemolytic anemia and sepsis, and the other 5 are alive and well. And in contrast to SCID in older times when they got to transplant with severe viral infections, Omen syndrome, these 6 patients got to transplant without viruses and without significant inflammation. None of them require systemic immune suppression before transplant. So 2 of them are quite early in the transplant process, 4 months and 4 weeks when I did this, and 1 died at 9 months post-transplant, and the other 3 patients, 2 of them have already stopped immune suppression and immunoglobulin replacement, and 1 of them still requires immunoglobulins. So the CTLs, they have, as I said, they have changed our management. We have used them since 2014 when we treated a patient with CMV encephalitis, and he had a beautiful response and cleared the viremia in the CSF. So, and since then, until 2022, 15 patients have been treated, 4 of them patients with immune deficiencies. And now we don't wait until the patients have a viral disease. We prefer to treat the patients when we make the indication when the patients have a viremia that is refractory to usual antiviral therapies, or the patients don't tolerate the antivirals for a number of reasons. So we have participated in collaborative studies. Regarding the CGDs, we have reviewed our experience together with the Spanish group for pediatric transplant, and we included 30 patients. And what we saw is that contrary to previous publications where these patients seemed to do very well, we found that we were facing a relatively high rate of graft failure and also chronic GVHD, and that the chronic GVHD-free survival was just here, slightly above 50%, wasn't looking great. So we need to make these transplants easier for this cohort of patients. And also here some more studies where we have participated. We have shared of our experience with the SKD cohort. We have shared our experience in the transplant of ARPC1B deficiency, CD40 ligand, and IPEX syndrome. And that's it of our experience. I hope I have given you an overview of what we are doing and how things have changed over time. Now is the term for adults. It's I have to tell you, it's a quite a smaller experience than this. I'm Laura Fox. I work at the transplant unit here in Vall Hospital since 2014. And I'm going to present you our experience in the whole process. So, wait a minute. We go. It's not going anywhere. There you go. So first of all, I wanted to kind of put like an introduction. These are the results of the last EVMT survey where we can see the main the distribution of the indications for transplant in allogenic transplant in adults. We can see that primary immunodeficiencies represent 4% of the whole indications in all the European centers. Our unit is much smaller. We perform around 35 to 40 allogenic stem cell transplant every year, and mainly because of neoplastic indication, as you can see. And since the incorporation of hematology in the inborn errors of immunity committee that was in 2017 at the end of the year, we have a really increased work activity in evaluating adult patients for transplant because of these indications. And this is was kind of already presented by Dr. Morris, and this is the process we perform with each patient we evaluate from transplant. First of all, we need to check the diagnosis to see, because things are changing all the time, and we are starting to find new mutations to identify specific primary immunodeficiencies, and that allows us to have more information about the natural history of each kind of immunodeficiency. So this is get to the point where we can evaluate if the transplant is really indicated. If transplant will have really a positive impact in the life of every primary immunodeficiency patient. As we saw in Dr. Morris' presentation, it seems that it does, but we need to be sure about the effectiveness of the transplant for that specific patients. And we need to put this, to weight the risk of transplant and the risk of continuing with a conservative treatment. So this is a very hard work in the first place. And then we have a specific problems that we need to know if we have a right donor, if our patient is fit for transplant, because usually adult patients, they have a longer follow-up, and they have more morbidities, more comorbidities that will make us evaluate if this patient is really fit for transplant or not. And then another chapter of this evaluation is to decide which will be the management of this patient until we get this patient to transplant, and which kind of transplant are we going to perform. So with all this in mind, it's like our main question all the time is really our patient fit for transplant? Because we need to perform this transplant before we have this concept, or we have clear this concept that we have to perform the transplant before a severe organ damage. But what is a severe organ damage? Where we should put the
the end of the indication. So besides using the classical transplant comorbidity index that it is validated for this kind of patients, but the validation cohort for this comorbidity index, we are going to see that there are many pediatric patients, not many adult patients, but we still have this score into account. But we have, as Dr. Marie explained before, we have a special, we have some specific end of organ damage that we have to take into account to decide if this patient is fit for transplant or not. There is especially pulmonary impairment. Most of our patients have inflammatory lung disease. They have structural damage, and probably the red light to not to go to transplant will be the oxygen dependence and the degree of the lung fibrosis. Also, we have to evaluate the hepatic impairment. Most of these patients have a nodular regenerative hyperplasia that is not a problem, but if this is associated to a severe chronic disease, that will be a liver synthetic failure, a decompensated portal hypertension with ascites, with a big splenomegaly, that could be that could contraindicate transplant. Then it's not quite frequent, but we can find renal impairment associated to primary immunodeficiency patients, and probably if we have a severe chronic renal impairment with clearance less than 30 milliliters per kilo per minute, that could be a contraindication for transplant. There are some places where they are starting to think about doing the kidney transplant first and then the bone marrow transplant, but well, that will be, we have to gather more information about that. And then we have the chronic diarrhea, malabsorption problems, active inflammation and colitis, that probably this won't be a contraindication for transplant, but will make things more difficult. And of course, splenomegaly for any reason, because we can have splenomegaly because of the portal hypertension, but also because a lymphoproliferative phenotype of the primary immunodeficiency. So all these are kind of special comorbidities that we have to really take into account before deciding if our patients are fit for transplant. And this is our kind of Bible for deciding if patients are fit, if we should proceed to transplant or not. Because it's not a straightforward decision, and patients are not static. They change over the time, and finding the right moment to perform the transplants could be very difficult sometimes. So first of all, we need to know if transplant will benefit our patient, if it will really make a change in the natural history of his particular primary immunodeficiency. And then we need to analyze, taking into account the patient specific comorbidity index, the specific end of organ impairment, and also if we know the specific genetics of that patient, in order to know if this is going to get worse. Probably most of all adult patients will be worse. If there is or there isn't a conservative treatment, and for how long can we keep that conservative treatment, and of course aspect related to the specific to the transplant, that could be which kind of donors, because we don't have much information about alternative donors. We perform with match related, with match unrelated, but after that, performing this transplant in adults with haploidentical or cord transplant, that could be quite risky. So with this, what we have done in this, since 2017 until now? Well, we have contraindicated transplant for a few patients. Most of our patients are chronic granulomatous diseased adult patients that haven't received this treatment during childhood. And especially the problem with these patients was that they were oxygen dependent, and one was sent for transplant after lung transplantation. So we consider that they were not, there wasn't much benefit in performing this transplant. Then, as you see, most of the contraindications are related with portal hypertension. Then we have a young woman with a BRCA2 gain of function disease with that she has a very progressed disease when an invasive squamous cell carcinoma that we didn't really thought that transplant at that moment with the immunodepression that will represent for the first year at least will help her to overcome this carcinoma. And basically, this is the main problem that sometimes adult patients is that they don't get the diagnosis in a very early moment of the disease. So by the time we have the diagnosis, or by the time we start talking with them about transplant, it's too late because we have an organ damage that contraindicates transplant. Then this is, as we talked before, this is a very dynamic evaluation. So we have patients that we know them, we know that they might have the indication of transplant in the future, and there are ones that act in active consideration for transplant. And as you see in the last 2 years, we have already these 5 patients trying to see if we find the right moment to take them to transplant. As Dr. Maurice says, we present them at their MDT committee to see, because sometimes it's quite difficult to decide that, because, for example, we have a young boy with no mutation identified, but with a PID phenotype with a mild or moderate end of organ affection, with pulmonary impairment, a liver impairment that is not as severe, but we have a bad donor. We have only a mismatch unrelated donor. So this makes us decide for now to wait, to keep on going with the conservative treatment, and we are going to wait if in the future he still have the indication for transplant. And with chronic granulomatous disease in adults, one of the main problems we have is that we have mismatch unrelated donors, and most of them have a very active disease. So this makes us doubt if they have really the indication for transplant, and not indication, but when is the proper time, the proper moment to go on transplant. And numbers are much smaller. We haven't done 100 transplants. We have only performed 7 transplants since 2015. And most of them were chronic granulomatous disease. In these patients, we perform reduced intensity conditioning. All of them were matched donors, some of them related, some of them unrelated donors. And we have pretty good results. Only one of them have a secondary graft failure, and that was the reason of death. We also performed 1 transplant because of cytopenias. There were autoimmune cytopenias with that were not treatable with conservative treatments. This was a male of 41 years old, pretty young, but with a previous lymphoma that he received a previous autologous transplant because of that indication. And he had a quite important splenomegaly also associated to all this. And he did a poor engraftment and an acute graft versus host disease, and he couldn't pass through the first 3 months of transplant. Then we have another 2 female young women that were transplanted because of GATA2. The main indication was because of the development of myelodysplastic syndrome, and these 2 women, they received a myeloablative conditioning, and they are alive with a moderate chronic graft versus host disease. So we also now, as you see, we use a flu almost for all of them. And now we also are changing, and the next transplant we are going to use tresulfan because we do have the indication. So that is all our little experience, but we really think that we need we need to improve the multidisciplinary team collaboration, the local one and also the international now, especially taking into account the small experience we have with adults transplant, to know which is the real indication, when to perform the transplant, and how to improve the general condition of patients before transplant. And for us, it's quite important to prioritize the diagnosis effort and to identify the genetic markers to really know the evolution, the natural history of these primary immunodeficiencies, and a collective effort to gather information regarding the effectiveness of transplant for this indication, and the natural history, because this will make the decision-taking process much easier. That's all. Thank you. Okay, so thank you very much for the attention, and well, now we can start for the questions. I don't know, Dr. Morris, are you there?
Yeah, I'm still here.
You're still there.
I am.
Hi.
Still there.
So, any question from the chat? No? Would you please check it? No? Okay. So, Emma, can I make you a question?
Yeah, go on.
It's great to see that IDDA seems to work better than other scores. Obviously, as you said, this is quite time-consuming to do so, and we are very used to do that in our IAI patients. But I was surprised because you already predefined 3 groups of low risk, high risk, and medium risk. And why, instead of that, didn't you try to find a kind of cutoff from which you could consider high risk and low risk? I mean, rather than predefining three groups.
Okay, so some of that, I'm just trying to see if I can find the slide that would be quite useful to show you. Some of that, do you mind if I see if I can share a slide in answer to that? Hang on a sec. Can you see that?
Not yet, but it's coming, I think.
Yes. Oh yeah, okay. So I'm gonna so partly because the manuscript is in the middle of being written, and when we got these preliminary results, we've gone back to the statistician to look at them. So in fact, what we might end up doing is having different groups of patients. So that's me being honest with you. It's a sort of work in progress. But what we think we will be able to do is to basically identify the very high risk patients who have a high HCTI score and a high IDDA score, and then some very good risk patients who have low HCTI score and low IDDA score. And then there'll be some patients who have a low HCTI score but a high IDDA score, and we'd think that they would be a low risk for transplant. But actually, if they've got uncontrolled immune dysregulation or uncontrolled infection at the time of transplant, that will increase their risk, and vice versa. And I think I'm going to see if this works. So when we looked at all of our patients, actually their IDDA scores and their HCTI scores weren't in a, I've got a laser pointer. They didn't go in a diagonal line. There's you know what I'm trying to say. There wasn't a linear correlation. So you've got a bunch of patients up here who've still got a lot of immune dysregulation, but have got a low HCTI score. And so what we really want to go back now, and I don't know whether we've got enough numbers, but to basically compare those 4 quadrants of patients and to see whether actually that gives us much better prediction on who will do poorly. But I think one of the other important things is it allows us to identify patients for whom some kind of bridging therapy or pre or peri-transplant intervention to reduce their autoimmunity or immune dysregulation pre-transplant is really important, because I think our experience is that those patients are the ones who are more likely to get GVHD and the patients who are more likely to get graft rejection because of the immune dysregulation. So it might allow us all to predict risk, but actually some of the components of the IDDA score are potentially reversible with additional intervention prior to transplant. So I'll stop sharing now. Did I answer your question?
That's great. Thank you. That's wonderful. I mean, you did. I mean, it's incredible. Go ahead, Laura.
Okay. Do you have any question? Yes,
Christina.
Christina was.
I have a question for adult patients. Managing mixed chimerism in patients who receive reduced intensity conditioning, then how you manage these patients, mainly those who were conditioning with Flumel, then maybe the mixed chimerism is higher?
Yeah, you're correct. It is. I mean, and so the simple answer is it really depends on their underlying immunodeficiency and what lineages are affected and what your degree of mixed chimerism is. So if they've got CGD and they don't get decent myeloid chimerism, clearly you want to do something about that. If they're patients with a combined immune deficiency, you really need their T and their B cell chimerism to be as close to donor as possible. We do have patients who've got complete clinical reversal of their disease and immunological reversal. So, normal subsets of cells, good numbers of naive T cells and B cells, T cell proliferation assays, vaccine responses without full donor chimerism. And what we're doing is trying to monitor that long term to see whether it actually how stable it is over time, and whether patients who begin to lose their chimerism clearly are the ones we worry about them getting a disease recurrence. We do use some DLI. It's hard. I think our data, we probably don't have enough numbers to really know how beneficial that is, and whether the risk of GVHD is the same, higher or lower than in our adult malignant population, in which we use DLI quite a lot. So I think the chimerism issue is not totally resolved in adult inborn errors of immunity. And but the only caveat, I mean, obviously, intuitively, if you want to cure someone, you want them to have full donor chimerism in all lineages. And so we have moved towards using sort of FTT-based regimens that are slightly more ablative. So they're not ablative, but they're sort of, I guess, what we'd call reduced toxicity rather than non-myeloablative. But again, that whether you can deliver that safely depends a bit on their comorbidities. So that was a very long answer to say, I don't think we've sorted it out yet, actually.
And just one question, have you observed lymphoproliferative disorders in these patients with mixed chimerism?
Yes, we have. And we have seen it also in patients with effectively full donor chimerism. We haven't seen it very much, but we've probably seen about, in that cohort of 82 patients, we see EBV reactivation, but not lymphoproliferation, which we just monitor and it settles down in probably about 10%. But maybe 5%, we've probably had about 4 or 5 cases off the top of my head who've had proper EBV positive lymphadenopathy, which we've given rituximab to, and withdrawn immune suppression, and they've all been okay. We do have one adult CGD patient at the moment who has got an EBV positive classical Hodgkin lymphoma, histology of EBV PTLD, who's actually receiving chemotherapy for that in addition to rituximab. So I think that's not a great outcome, because when you look at the data on that particular variant of PTLD, I think they're the ones that do less well. Most of the other patients respond very promptly to rituximab. And we use Campath quite a lot, and I think that probably helps a bit because it gets rid of most of the B cells as well as the T cell depletion. So compared to using ATG, where I think that there's a higher incidence of PTLD.
I have a question for you. Taking into account what you have show us about the reduction of the inflammation after transplant, do you think that is necessary to have an absolute control of the inflammatory bowel disease or colitis before transplant? Would you would you delay the transplant because of that?
Yeah, good question. So our experience with colitis, and not just CGD patients, but sort of ZIAP patients and DOC patients, other combined immune deficiencies who have an inflammatory colitis. We haven't delayed transplant, and we've done patients who've been on biologics in addition to steroids who've gone into transplant with sort of diarrhea, 8-10 times a day. And they've all responded really beautifully. And we haven't seen an increased signal for gut GVHD in those patients, which we were a bit worried about because of the sort of inflammatory milieu in the gut, whether that would attract the alloreactive T cells. But in our experience, it hasn't. And maybe that reflects the degree of T cell depletion we use. I don't know. But so we very definitely don't delay transplant for inflammatory bowel disease. The ones we worry about are the ones with chronic norovirus as well. And I think the pediatricians tend to not worry and just go ahead with transplant, and we're a bit more nervous with the adults. So I don't really know why. Maybe that's lack of experience. But it's hard to get rid of, but you all know that. But if you talk to some of the pediatric transplanters like Andy Jennery, they don't seem bothered at all by kids with norovirus going into transplant. I don't know whether that's a general thing or just a Newcastle thing.
Yes, maybe. Well, I don't know if there is another question. No.
Do you have any explanation for the different results of the, let's say, Spanish cohort of CGD patients when compared with what is published in the literature? I mean, because as immunologists, we were quite excited in terms of the results with reduced conditioning, but we are seeing that our patients are behaving somehow differently. So is there any explanation of that?
So I don't have an explanation. No, the short answer is no, because the donors were not that bad donors. There was more, the donors were mostly sibling donors or match unrelated donors. And most of the patients got to transplant with the controlled inflammation, and the transplant were performed in the 5 units that had more experience, more transplant experience in Spain. So I don't have an explanation for that, but I know that to me, CGD patients are different, transplanting CGD patients are different to all the other immunodeficiencies. So they behave completely differently. They have a very, they used to have a very complicated post-transplant, even though maybe 1 or 2 years after transplant, they are doing well. They have, many of them, a crazy post-transplant first 6 or 9 months, and that's not something we see with HIAPs or SCIDs who come to transplant with with active diarrhea. We don't bother at all with CAPS or kids with diarrhea, but CED patients, I don't know why, in Spanish hands, even if they got to transplant in perfect state, with even much sibling or much unrelated donor, they don't do so good. So we have now just performed our first haplo with alpha beta depletion in one of our patients. She's a teenager, still 5 months after transplant. She's doing well, but she has had some complications. So we'll see the role of haplodepleted alpha beta for those patients.
Thank you, Laura.
I just have I have many, but just one more question. Do you have any experience with cyclophosphamide post-transplant for pediatrics or adults? Because it seems a kind of good strategy, especially when we go to transplant without control of the inflammation or the lymphoproliferation.
So I will reply. So we have more experience in leukemia patients. And for the immunodeficiencies of immunity, we have performed some haplotransplant with the post-transplant site platform, but these were for graft rejection. So we rescued patients with graft rejection last year, and these were successful transplants for the rejection. Then when the data, and then regarding alpha beta depletion or post-transplant site, there are some preliminary data that was presented in BMT last year that seems to be favorable for alpha beta depletion in CGD, but there is an ongoing study. So that's when we decided to go with the alpha beta depletion for our non-malignant patients.
Emma, do you have any experience with post-sci?
Yeah, we've used it once in a patient who had a early graft failure, but he was retransplanted with a haplo, and he's had quite bad GVHD. And we have 2 of our most recent patients who weren't in that cohort had mismatched unrelated donors, and we use PT-Sci. We use PT-Sci for our malignant haplos rather than alpha beta TCR depletion. And they're both doing okay, but they're quite early. They're sort of 4 months post-transplant. So we're only just beginning to use it. I mean, I guess if we extrapolate from the general adult heme malignancy practice, where it's being used quite frequently, and also the bigger center pediatric practice, I think there's probably no reason not to move towards that, but I don't know, it's difficult. It just always feels a bit scary doing something new.
Yes, absolutely. Okay, if no one have more questions, okay, thank you very much to all of you for the presentations and for the questions. And well, we can keep on going with the schedule. Okay?
Thank you. I'm going to leave now.
Take care. Bye.
Bye-bye.
Bye. So just to adjourn the meeting, we wanted to know how patients and families were facing a transplant, and the initial idea was to ask our psychologists to told us about that. But we thought that that was not the right way to approach to that, and we directly asked our patients. So it's a short video, it's 9 minutes. It's quite emotional rather than testimonial. I hope you will enjoy it. For the online attendance, we had no time to subtitle it all. There are speakers in English and Spanish and Catalan, but once we will share that with the subtitles once they are there. I hope this is going to happen very soon. So please share the video. I think that you will enjoy it, and it's a kind of homage to all the patients, all the families, and also all the healthcare professionals that take care of the patients, both on the pre-transplant, during transplant, and post-transplant steps. So, John, please.
It was fairly poor since Edwin was so vulnerable without a functional immune system. We couldn't leave the house. It was absolutely necessary. And the diagnosis made the first part of his life very difficult.
Sobretot teníem problemes digestius, sempre en diario, quan era petit tenia les pobretes, és a dir, feia diarrees amb sang, això va anar-se feien amb el temps, va anar-se suavitzant, però sí que cada X temps tenia mal de panxa, diarrees i diferents àrees diferents. Sempre em trobava com molt malament, llavors no tenia moltes forces i no sortia molt de casa. Sí que és veritat que sí, anava a l'aire sobre això, però mentre passava el temps, cada vegada tenia menys ganes i em quedava més a casa.
Depèn del dia. Hi havia dies que sí que eren novells, no? Tractava de febre, però hi havia dies que...
Perquè pocs dies van començar a sortir cosetes i van començar a fer estudis. Els vam tenir directament a la biblioteca i aquí es va quedar interessats. O sigui que va ser anar digerint mica en mica la notícia. Sí que ho recordo com un moment forçat.
Ja comences a plantejar tot, no? Has de decidir i que hi ha una referència. También que el señor Mundial.
She told us that he had SID, severe combined immunodeficiency disorder, that he was a bubble baby. And it felt like the world was coming crashing down around us. The baby that up until that point we thought was completely healthy had a life-threatening genetic condition. And it was probably the most difficult weekend of our lives.
L'únic que vam pensar en aquesta bèstia i ara ho ha fet que és el segon pas.
Sí, perquè és 5 setmanes i clar, era una mica agobiant per part de a la tercera setmana ja podíem arribar a la meva petita i no hi havia dutxa, ho havia fet com una poder i com portant cada dia l'aigua, més l'aigua s'ha calenta. Però agobiant. Sí que és veritat, poder posar un llibre de la biblioteca i tot, però realment el que em trobava més mal passada realment era la ment, perquè jo sempre m'ho deixava, perquè estava com molt preocupada.
And how we have a dedicated team, including psychologists, the whole family. And Edwin's initial visits to the hospital Belgium and Vall were very well organised, and we felt well supported through this. During the transplant itself, the systems in place to protect Edwin seemed rigorous, and the nurses that looked after Edwin and my wife Miriam throughout this treatment were absolutely amazing. Obviamente nada más que lo primero es avisaron. Y bueno, que luego se deben aprender a hacer piña, a hacer aquí, a saber dejar-nos ajudar per tot i l'equip de professionals dins de l'hospital i fora, des de la família, amics, però sobretot dins de l'hospital.
I quan em van dir que ja estava, se'm va excusar, clar. Quan era la mare, jo vaig anar a la guia. Perquè sabia que ja està.
És obert amb un fill, una fortalesa que podien sumar que hi era prou de desconeixer, que fos fins a aquest punt, i habitualment, clar, en aquell moment, passes hores i hores amb aquell fill. Al principi va començar a jugar al mòbil, però fins i tot ell va arribar a un punt que va dir, estic de mòbil, i llavors és parlar de mil coses que no tenen res a veure, una malaltia, una intervenció, compartir amb les infermeres, amb els auxiliars, també tenia coses positives, perquè doncs, també podia seguir com jo amb els meus estudis. Encara que tindrà això, doncs, a l'hospital m'hi estudiava això i això, només per mi era una distracció, tenia moments de distracció i això és el que m'ajuda també a sentir-me millor.
A veure, que ens va ajudar, sobretot, jo crec que és que es va dir que era un procés dur, però que era un procés curatiu. Vas saber que, dins de les malalties, dins de les immunodeficiències, hem tingut entre cometes la sort de que hi ha una cura i saber que ara és, sobretot, un camí que hem de fer, que si era una mica, però que ja
aquí és on jo m'he agafat sempre, el tema. El problema és que no té cura. I sí que hi ha problema. Però no té cura, agafes allà, com n'hi ha sempre, si per la meva.
Està bé per part la teva. I així, no sé, preguntar a veure si passem amb alguna cosa.
Por lo menos a soltar, a poder llorar, a poder nunca lo debemos hacer, para entrar a un sentado, si tenemos que reír, bailar, cantar, y no me ve, tenemos que intentar que eso estuviese bien.
It's helped for sure. Victor, our psychologist, is absolutely brilliant. And when I was having trouble sleeping during Edwin's treatment, Victor helped. He gave me some tips on how to manage my fears and my anxieties, and I slept better as a result. And he's also provided support during the most difficult part of Edwin's treatment.
Em va ajudar moltíssim a entendre on estava i arribar jo a les conclusions que vaig arribar, que no és jo les sé, però sí m'ha ajudat moltíssim a avançar i aprendre i m'han donat molts recursos.
Si no hubiese tingut suport psicològic, la meva vida sense negociar, segur. Segur. La Laura estava doncs. Segur, perquè és molt complicat. La vida.
El pre-trasplante estaba es una niña enferma prácticamente desde sí. Tenía que planificar en cualquier momento, pero sí.
Ara és perfecte. I més ara que hi ha una planificació, va ser un punt clau.
Fantàstic. Medicació ja... No me'n recordo ni del nom dels medicaments que prenia.
Pues ara a dia d'avui seguir el meu per exemple, vaig a la universitat, torno a casa, quedo amb les amigues, llavors és com un ritme de vida que puc tenir, perquè realment abans no teníem.
Va suposar canviar una mica els valors, fonamentar les coses.
Valores de salud que antes no pensaba siquiera en si puedes enfermar o clínico,
Ves que hay otra vida. Y avanzar la vida es una cosa. No es ni diners, ni cosas materials, ni la vida és temps. És que només és temps. Hi ha temps com a vulguis passar i amb qui el vols passar.
I això també m'ha gustat molt. M'ha gustat molt entendre-ho. El fet d'aprendre a que ja no soc un malalt.
Jornada. So we are done. And it's time to adjourn the meeting. We're 20 minutes late, so sorry for that. And I'm happy to be here to turn the meeting together with Christina, because obviously, as has been said in most of these talks, this is a teamwork with the only aim to improve patients' life, and there's a lot of people doing their job. So Christina, if you want to finally adjourn the meeting, it's up to you.
Thank you very much. Thank you very much to all your speakers, because the meeting was really fruitful, and I think we learned many things, and we are concerned about many problems that we face in the pre-transplant period and also in the post-transplant period. And thank you very much to the audience also for your attendance and for all your questions. Thank you very much also to the Primary Immunodeficiency Foundation, because if this session has been possible, thanks to your, I don't know how to say, but to your promotion or your efforts mainly. And so thanks a lot.
Thanks a lot, Christina.
So.
And this session will be, has been recorded, and we'll try to upload it in YouTube, and please get in contact with us, and our technicians will let you know how to manage this. So once this is done, we can adjourn the meeting. Again, thank you to all the speakers and to the attendees, and see you in the next meeting. Bye. Bueno.
Sí, no sé, pero después la vídeo.
Bueno, es que no lo voy a